Thank you for joining us at the Indiana Family and Social Services Administration's quarterly financial review. We will begin with the Division of Family Resources. A reminder, if you have a question, you can either email the askthesecretary@fssa.in.gov email address, or we have note cards back here. You can grab a note card and write that question down there, and we will be asking those questions at the end of the presentation. Thank you.
Good morning. I'm Sunshine Beam. I'm the Director of the Division of Family Resources.
I'm Kevin Eustace. I'm the Controller of Division of Family Resources.
Is this on? Can you hear me now? Can you hear me now? Okay. Okay. DFR administers eligibility for Indiana's key safety net programs, including Medicaid, SNAP, and TANF. The division manages applications, renewals, and case maintenance through 102 statewide offices, ensuring accurate and timely service delivery. DFR's performance directly supports program integrity, federal compliance, and responsible stewardship of state resources. DFR has 101 local offices and 10 regional change centers across the 10 DFR regions. And DFR leases approximately 846,000 square feet across the state. In SFY 26, DFR saw 1.2 million walk-ins served in its local offices. We took 3.1 million phone calls. We received approximately 1.3 million applications received across the three programs. We completed approximately 1.5 million redeterminations across Medicaid, SNAP, and TANF. And our total SNAP issuance for SFY 26 was approximately $1.3 billion. And the total TANF issuance was approximately 24 million. Here's our quarterly financial review outline of the things we're going to cover today.
Here's just a summary slide of the financials for each program that we'll be discussing further in detail later in the presentation.
One of DFR's key safety programs is SNAP, the Supplemental Nutrition Assistance Program. The Supplemental Nutrition Assistance Program provides food assistance to low-income individuals. It is a federal aid program administered by the Food and Nutrition Service. Distribution of benefits occurs at the state level. Benefits are provided on an electronic card that is used like a debit card and accepted at most grocery stores. The benefit is currently 100% federally funded. The administration costs of the SNAP program are split 50%, with 50% being funded by the state. This changes to 75% state funded in October of 26. The SNAP program saw a number of changes in SFY 26. We had changes to the SNAP.
Sunshine, if I may, I just want to go back to SNAP for a moment. And thank you and your staff for the tremendous work you did, particularly when SNAP was shut off in getting it turned back on again effectively. And that's a hiccup, which I hope we don't have to deal with again, but you dealt with it with aplomb, and your staff did. And frankly, our recipients were pretty understanding as well. So
they were. We are going to consider that a success. We had some other significant SNAP changes in SFY 26. We had changes to the SNAP work requirements for able-bodied adults. The age limit increased to 64. It limits exceptions of a parent or household member with a dependent child to 13 and under. It was previously 18 and under. And removed temporary exceptions for homelessness, veterans, and former foster care children under age 26. So this means that there are more people considered able-bodied adults under the SNAP program than there were previously. There were changes to non-citizen eligibility, which resulted in some non-citizens being no longer eligible for SNAP. We implemented the Smart SNAP program, which are the food restrictions for not being able to purchase soft drinks and sugary drinks and candy with SNAP benefits. And then we started requiring additional verification of Indiana residency. There are upcoming SNAP changes that are a result of HR 1. The SNAP admin state share increases to 75% effective October 1st, 2026. Their estimated fiscal impact for SFY 27 is $37 million. The annual estimated fiscal impact is $47 million. Additional state share. State share of SNAP benefits will be based on the SNAP payment error rate, with our fiscal impact being between $71.5 million and $214.4 million. Effective October 1st, 2027, this cost share will be based on the error rate for 2025 or 2026. Our SNAP issuance in 2026 was approximately $1.27 billion. And here's a breakdown of what the cost share entails. So there's no cost share of the SNAP error rate if the state's error rate is 6% or less. If the error rate is between 6 and 7.99%, the state share is 5%. Between 8 and 9.99%, the state share is 10%. If the error rate is 10% or greater, the state share is 15%. Our error rate in FFY 25 was 9.77.
I've always been a little confused in terms of how error rate is calculated. Can you articulate that for me?
Oh, that's a trick question. I'll do my best. FNS required, the federal government requires that we pull a case sample every month. It's approximately 100 cases. We pull that sample, it gets reviewed for both under issuances and over issuances. And then we compare the error rate dollars, which is either benefits that were not issued correctly or benefits that were over issued, compared to the SNAP dollars in the sample. And then that gives you your payment error rate.
On a monthly basis, how many redeterminations or determinations for SNAP do we make?
About 20,000.
And they only look at 100?
Mm-hmm.
And are we penalized if the recipient either intentionally or mistakenly provides information that is in error?
Yes.
So so what you're telling me is that out of several 100,000 redeterminations or determinations, they're going to look at 100. If the recipient intentionally or unintentionally makes an error, they're going to charge the taxpayers of Indiana $63.7 million?
Yes, that is correct. Currently, the federal regulations require that the state is responsible for non-reported for client errors.
That seems fair.
Right. Our current, and I know somebody's probably wondering, our error rate is currently for federal fiscal year 26 is trending down in the right direction, with our goal to be below 6%. We do have some additional upcoming SNAP changes as a result of SEA 1 here at the state level. We had an elimination of broad-based category eligibility for SNAP effective July 1st. This law restores the federal asset limits for SNAP applicants by ending expanded categorical eligibility. So the federal asset limits for SNAP are $3,000 for a non-disabled, non-elderly household and $4,500 for elderly and disabled households. So we have lowered the asset limit back to the federal standard. And then we have stricter verification requirements for income, resources, and immigration status. And as far as the breakdown of average number of recipients and applications and redeterminations, for SFY 26, we had an average number of recipients of 538,000. The average number of households was about 261,000. We received total number of applications for SFY 26. We received 400,955. Total number of redeterminations that we completed were 163,071. And as I previously stated, the total issuance for SFY 26 was approximately $1.27 billion.
Here's the program summary for SNAP admin. One thing I would like to point out compared to previous QFRs, we would capture a forecast to show you what we're projecting to spend. Since this QFR is based on year end, you'll only see actual spend. So the actual spend for SNAP admin was 5.2 million, which left us in a positive variance of 1.8 million. And that was basically due to vendors submitting a little bit under the monthly average for the contractual expenses. SNAP impact, the actual expenses was 3.5 million, which gave us a positive variance of 3.6 underspend. But for this one here, we project that some of those expenses are going to occur in SFY 27 just because vendors were running late on payments. For EBT, the actual expenses were 395,189, which gave us a overspend of 149,000. Last QFR, we were projecting a overspend of 136,000.
Can we stay on EBT for just a minute? So Sunshine, I regularly get complaints that somebody's SNAP benefits have been stolen. What could they do to alleviate that risk?
They should be locking their cards, and we have those instructions on our FSSA website, which you can get to at myfssa.in.gov. There's instructions on how to do that in the website. And the best thing to do is just to regularly change your PIN and to lock your card in between transactions. We're currently working on some solutions, and I know we've been in touch with the Office of the Inspector General at the federal level on some of those concerns, but it is, it is just unfortunate because we are not able to replace benefits right now due to legislation that was passed in 2024. So we are unable to replace those benefits when they're stolen. So it's important that everyone lock their card. Temporary assistance for needy families is also another safety net program that DFR provides, and it provides cash assistance and supportive services to assist families with children under age 18 and pregnant women. The goal of the TANF program is to help individuals achieve or return to economic self-sufficiency. As a condition of eligibility for TANF, adult applicants are required to attend applicant job search orientation and to complete applicant job search activities. Failure to complete these applicant job search activities without good cause will result in a denial of the application for cash assistance. Applicant job search started in November of 2011.
Here's just a capture of TANF funding allocated out to other agencies outside of DFR.
And as far as the TANF program, we had an average applications for SFY 26 of 5,340. We did an average of 388 TANF redeterminations every month, and then we issued approximately $6 million every quarter. And the total issuance for SNAP for SFY 26 was $24 million. And the average number of recipients receiving TANF is 11,762 for SFY 26. And you can see the majority of those are children, with the 9,338 of the recipients for TANF being children.
For a TANF admin, we had 65 million in actual expenses. which left us in 11.2 million underspend. And that was mainly due to contracts. The vendors were submitting lower than their monthly average. And then also for our TANF cash assistance, it was a little bit lower than we anticipated. But I mean, last QFR, we were projecting 11.2 million underspend as well, though.
The Indiana Manpower and Placement and Comprehensive Training Program aims to help participants achieve economic self-sufficiency through a combination of education, training, and employment services. Services available include job skills training, assistance with resume writing, interview preparation, and access to local job fairs and employment opportunities. The Impact Program is available to SNAP and TANF recipients. For SFY 2026, we had a total of 3,743 SNAP recipients participating in the Impact Program, and we had approximately 2,039 recipients participating in the TANF Impact Program. And we're going to jump to the Medicaid eligibility numbers. We had an average number of Medicaid recipients for 1.65 million for SFY 26. That was an average. We received a total of 811,171 applications, and we completed approximately 1.3 redeterminations for Medicaid. Indiana's refugee program provides assistance and services to refugees, asylees, certain Amerasian, Afghan, and Ukrainian immigrants, Cuban and Haitian entrants, and victims of human trafficking. Indiana Refugee Services monitors program planning, provisions of services, and provides technical assistance to ensure in compliance with federal and state regulations governing the delivery of federal assistance and services, including cash and medical assistance. All individuals served by the Indiana Refugee Services have legally entered the United States through applicable federal programs. The refugee program was paused in early 2025, but was restarted in November of 25. Indiana has received 78 refugees from November of 25 through June of 26. And we provide specific refugee medical assistance and refugee cash assistance to recipients. And in SFY 26, we had an average of 785 individuals on refugee medical assistance, and then an average of 449 individuals receiving refugee cash assistance.
For refugee, the actual expenses was $8 million. Here we're showing a 24.2 million underspend, but that's not really accurate because the budget was based on FFY 25. And due to the changes in the refugee program, that's why it's showing something that's really not accurate here, is because our budget wasn't based on the actual recipients planned for FFY 26 due to the changes.
There we go. The Burial Assistance Program was established by the state of Indiana to help with burial costs for those who are eligible in specific categories of Medicaid. The maximum benefit amounts are $1,200 for a funeral and $800 for cemetery. In SFY 26, we provided services for 938 cemetery claims and 4,603 mortuary claims for individuals who are on Medicaid.
For burials, the actual expenses were 6.2 million, which we had 436,000 overspend. Comparing to last QFR, we were projected 491,000 overspend. For county admin, the actual expenses was 278.5
We
million.
can go back to burial. So it's, this is a sad thing, though, what I'm gonna articulate here. But we get no federal help for this program.
Yeah.
And our cemetery expenses are not insignificant. I think we need to have a serious, and I would invite others to chime in on this to us regarding it, but do we really want to continue to do cemetery, or do we just move everything to cremation? There may be religious reasons why that's a bad idea. But I think we've got to ask ourselves whether or not a cemetery burial is something that the taxpayers ought to be funding. That's just a statement. I'm not asking to have a policy discussion on it today, but if people in the room have thoughts about it, they can email us their opinions on this. But we need to, I think, at least think about doing that. So thank you.
County admin, the actual expenses were 278.5 million, which we're showing here a 4.2 million underspend. But last QFR, we were showing a 12.8 overspend, which we still anticipate this program to be overspent. The difference here is the actual expenses for contracts you'll see was 156.5 million. And we are still making payments on those contracts. They're just occurring now instead of last fiscal year.
This is the DFR staffing summary. I'm going to flip forward and do these a little bit out of order. Sorry about that. The DFR staffing changes. In November of 2025, an additional 65 state eligibility workers were added to provide additional oversight to decrease the SNAP error rate. This support unit is called the Central Integrity Review Team, and as of July 24th, 2026, 56 out of the 65 approved positions have been filled. And additionally, in March of 2026, an additional 400 state eligibility staff were added to DFR staff. These staff were added to support Medicaid community engagement or the work requirements and other changes related to SEA 1 and HR 1. As of July 24th, 2026, 344 of the 400 approved positions have been filled. And here is the summary. Our average head count, the average number of state employees was 1,297, and then the average number of contractors was 1,677, with our average total staff for SFY 26 of 2,974.
For DFR admin, the actual expenses for year end were 4.6 million, which we had 178,239 underspend. Last QFR, we were projecting 153,000 underspend, so no major changes here. For IADS, the actual expenses were 34.6 million, which we're showing 756,000 underspend. Compared to last QFR, we were projecting 1.1 million overspend. And that's just due to, if you look at point 3, you'll see a $2.5 million variance there, but that's due to our vendor Deloitte. They were running behind on some claims, which we anticipate to pay in this fiscal year. And here's just a summary of DFR's major contracts.
Can you talk a little bit about what we're doing with work requirements and how that's rolling out across the state?
I will try my best. We have some, as far from a communication standpoint, we have notified recipients who are currently on HIP who could potentially be required to participate in the work requirements. Let me back up. First of all, the work requirements only apply to our expansion population. So individuals, children who are on Hoosier Health Wise, individuals who are disabled, the aged, they are not required to participate in the work requirements. I think that is maybe some confusion that's out there. So just to level set, we are only talking about the HIP expansion population. There are a number of exemptions for this group, which can also be found on our FSSA website at myfssa.in.gov. We have all of them listed. And we are working on, right now, our biggest focus has been on communications. And the FSSA communications team has done a great job. We have some town halls scheduled. I believe that announcement will be going out if it hasn't already gone out. We have text messaged individuals who potentially have to participate in the work requirements with some preliminary information. Individuals have been mailed notices. We are starting to really get all that information out there, and these town halls are public, so anybody who has any questions or wants more information. We've been working closely with our federal partners at CMS to get some answers to some questions that we have in relation to how we should implement here in Indiana. And we're just working closely with our federal partners to make sure that we do the right thing.
And how far back how will we be looking? So if you were to apply for as an expansion, as an able-bodied adult in January, how far back would you have to have proved some kind of community engagement?
You will have to prove that 3 months retroactively. So if you apply in January of 27, you will have to prove that you're working or somehow engaged in the community for October, November, and December of 2026.
And is there an electronic mechanism by which the recipient or potential recipient might submit this information?
There will be. It's currently not in production because we're not that close yet. But as we get closer to that, and all of that will be communicated when we're ready to kick off. But yes, we will be able to. Individuals will be able to use the FSSA benefits portal to upload that information directly to us. So individuals right now can, in order to set themselves up, can go to fssabenefitsportal.in.gov and go ahead and sign up for an account and get yourself familiar with that as we're making those changes to provide information about work requirements in that portal.
And whose responsibility is it to make sure that the individual maintains their eligibility?
It is the member's responsibility. We'll do our best to assist and provide you with information, but it is the member's responsibility.
Thank you. We have a couple of questions. First one is from Art Filler at hamiltoncenter.org. For the error rate, do we have an estimate on how much of the error rate is related to underpayment versus overpayment? And if so, what is that estimate?
We do for SFY 25, I believe, but I don't know. Marcus, I'm sorry, I don't know what that is off the top of my head. I can send that to you.
Yeah, Art, we will get that answer to you. Next questions are from Emily Bryant, the Executive Director of Feeding Indiana's Hungry. What funding source is FSSA using to cover the additional SNAP admin share?
We're currently working with the state budget agency to determine how that's going to be covered. And as we're looking to the next biennium budget and putting those together, we're currently looking at how that's going to be funded.
And her next question is FSSA including an amount for SNAP benefit cost share in the agency's budget request?
Again, the next biennium budget has not been put together yet. And our CFO and our controller, myself, secretary, are all currently actively working on that.
She also adds, great job with the downward trending error rate. And that is it for questions for the Division of Family Resources. A reminder, again, you can still ask questions at the Ask the Secretary at fssa.in.gov email address, or you can still fill out cards. Questions that we don't answer here today will be answered in writing. Thank you.
Thank you.
Now we will move on to the Office of Early Childhood and Out of School Learning. Coming up, another reminder, you can ask questions at the Ask the Secretary inbox at askthesecretary at fssa.in.gov, or we have note cards back here. You can come grab a note card and fill those out. We will be asking these questions at the end of their presentation. Another note too, if you ask a question and you don't hear it read now, chances are it's more appropriate for another division, so we'll be saving those questions for that division's presentation. Thank you.
We'll get started here. I am Adam Alson, the Director of the Office of Early Childhood and Out of School Learning. This is the state fiscal year 2026 quarter 4 quarterly financial review. I have Christy Burkhart here, the Senior Director of Provider Supports, and then also Lisa Metler, Senior Director of Family Supports and Program Integrity with me as well. We usually have a kickoff slide. I kicked it out of this one because we've done it enough, but just as a reminder on what the Office of Early Childhood and Out of School Learning does, is that we administer funding for childcare programs. The major one is the CCDF voucher program for working low-income families. And we also regulate the roughly 4,000 childcare businesses throughout the state of Indiana. I mentioned it once, but I think it's worth saying it again, is, our voucher programs, both CCDF and then our On My Way Pre-K program for 4-year-olds, they are work programs. They are one of the requirements of receiving and maintaining a voucher is either being in the workforce or being a part of post-secondary education in some way or credentialing. Biggest thing over the last few months has been, in our space, has been the additional $200 million of FROG funding, state appropriation to the $200 million augmentation of the Financial Responsibility and Opportunity Growth Fund, or the FROG Fund, for CCDF vouchers in order to enroll additional children within the program. This was approved in April by the State Budget Committee. We began enrollments in May of 2026 here. We're going to be giving some more information very quickly here about updates on enrollments, and then also on total voucher amounts and enrollment in the state of Indiana. Just as a reminder, we did this through a two-pronged approach. The first one is a set-aside approach, which has various priority groups, which we'll get into in detail where we are on those here shortly. And then also through priority groups, starting with siblings of current voucher holders, infants, toddlers, then 3s, 4s, and 5s. And within each of those priority groups, first in, first out. So I'm going to hand it over to Lisa Metler here for the next little bit to talk about where we are on our CCDF voucher enrollment.
Thanks, Adam. So far we have invited 9,000 children to the vouchers, and 36% of those children have been enrolled since May of 2026. And 90% of those filled slots went to, better? No? Is this better? Thank you, sorry. 36% of invited children were enrolled since May of 2026, and 90% of those filled slots went to siblings already receiving, their families were already receiving vouchers. And so while overall enrollment is important, we also wanted to ensure those set-aside populations were receiving access as well. And so our next slide shows those priority groups and their description, and how many of those children have been enrolled in each of those areas, with, like we said, the siblings are leading that charge there with just under 3,000. We also have another opportunity within our vouchers, and that's through the Preschool Development Grant. And that grant has allowed us to strategically build infant and toddler spots for CCDF eligible families and capacity where Indiana needs it most. And this is 1,000 new slots were designated. As of 7/22, we had 838 slots filled, and there was a 45% reduction in infant and toddler wait list with this eligible funding that we have available in 33 high-need counties. Those include 16 rural, 11 mixed, and 6 urban. So with this, we've been able to see some enrollment gains And just being able to reduce that infant and toddler wait list by 31% since 2020, since April of 2026, when PDG started. And then we've had collaborations with 11 Head Start programs who have been able to enroll 41 infants and toddlers through the PDG pilot, and as well still working closely with DCS for that foster kinship placement for those families.
Thank you, Lisa. Next couple of slides here is just a reminder on what from the state of Indiana's perspective, what an additional voucher, CCDF voucher actually is. It is at the end of the day, it is a set of cash flows with complex embedded optionality that in aggregate creates a multiple year obligation of uncertain length for the state of Indiana. So what that means here going forward is we continue to enroll children and families onto the CCDF voucher program, that one, funding decisions in future state fiscal years must take this into account. And then also, there is always going to be some uncertainty around the variability of what those cash flows will look like, projections versus actuals. Note that the average life of a CCDF voucher is 2.5 years. And that means that upcoming enrolled vouchers will exist longer than the end of state fiscal year 27. We fully understand this, and the governor will be supportive of additional funding to continue to fund these vouchers in future state fiscal years. Graphically, here's where we are. You seen this graph the last time. This is a historical graph of our existing and historical CCDF voucher enrollment, and then where we are versus a funding perspective. The solid green bar down at the bottom is effectively what the early childhood learning state line item in the state budget can fund from a voucher perspective. The larger box is our current federal funding. So that is a combination of child care development block grant funds, and then also TANF funds that get transferred. And then we also have the FROG fund there, which is effectively 1 year, $200 million. We're targeting going from effectively 43,000 vouchers total to 57,000 vouchers. The red bar is what is currently that will be future requested state appropriations. So from a historical data, so we're going to get into some data, a little bit of data here around our programs.
Can we, before we do that, can you go back to the last slide?
Yes.
So that slide suggests that the uptick in participants outstripped the original appropriation, and that we have moved into some of the FROG funding.
We're beginning to, yes.
Okay. And before we did FROG, what did we do? Before we asked for the FROG funding, what did we do?
We cut costs internally.
No, we went out and we looked at every single, to make sure we went out.
Apologize. We did a lot of things, Secretary Roob. We looked at our own costs, said, hey, what's more important? Is it CCDF vouchers and children and the indirect support that provides the child care supply side? And then we also went out and spot checked a vast proportion of the child care businesses throughout the state to make sure that when they say that they have people and children in their services, that they are there.
They were not leaning centers. Right. And what was that process called? Do you recall?
Well, I remember it stood for TOAD, but it's Total Operational Analysis of Daycare.
So before we got the FROG funding, we did TOAD?
Yes.
Okay. Thank you.
Historical data, a couple graphs to see them always here. One on the left is total regulated childcare capacity. Regulated childcare capacity in the state. It has, I think, over the last few months, we can see it started to even out here after a slight decline in the first part of the calendar year here. And then also on the right, this is our total voucher enrollment. So this is CCDF plus our On My Way pre-K program. And we can see the enrollment gains that we have made through beginning to execute the FROG funding in the FROG program. So this presentation is for the end of 6 to 6/30 of 2026, which is the end of the state fiscal year. However, we know these numbers are important to the space. We have numbers for also July, so ending 7/31 of 26. Here's where we've been over the last couple months. So you can obviously read them all, but our total voucher number for On My Way pre-K and CCDF is, as of July 31, is 48,193. Our total wait list is under 30,000. So that is a decrease of 25%. We want that. We're going to keep churning through that. And we can see down at the bottom, total families for vouchers for employment is 94%, and single parent households are 92%. Well, I will pontificate. Okay, there we go. Okay, so this is more of a breakdown and more historicals around the data around CCDF voucher statistics. Note there's a couple. The first part is enrollment. Our CCDF vouchers are at 45,494, which is a increase of around 6,000 since the low in March. And then also on the On My Way pre-K vouchers, we are currently enrolling 2,700 children. Note that that enrollment period is ongoing. We expect that to be a little bit higher. We are seeing increased interest in that versus last year, where our maximum as on this in June of 2025 was roughly 2,200. Wait lists, you can see that, and then our reauthorization rates, it's at 68%. And it's there may actually be a little bit of seasonality in there, which is interesting to see.
So Adam, can we flip back to the last slide? So the wait list declining is obviously a positive, right? But the wait list is likely not static.
It is not static.
So of the 29,000 people to children who are on the wait list, do we know how many were added between June and July?
We can get that number for you.
Yeah,
I don't know if we know it off the top
It's
of our head.
I mean, the question we had here was, what's the woodwork effect of this policy change?
It's less, I will say it's less than what I thought it would be. And there may be a lag effect on what that woodwork effect is. It may show, I would expect it to show up over the next maybe 6 months, where now that this program is being funded, and that sort of word gets out to the populations that we serve here, we should expect to see, as we're working through our wait list, there will be more people that will come online.
Okay, thank you.
Mm-hmm. Okay, so this is a breakdown of by age. So as of July 31st, we have 2,100 infants, 7,700 toddlers, 21,000 3s, 4s, and 5s, 17,203 school age, and for a total of 48,193. Note that we have focused on infants and toddlers, specifically infants. We fully understand how important that these vouchers are, both for families, but also for the broader childcare space as well. Which is one of the main reasons that we did target infants and then toddlers. As Lisa said earlier, we're getting, I think we're either very close or we're on our last round of working through our siblings that we had currently on the wait list. And so our target from an enrollment perspective will be those infants and then toddlers subsequently very, very soon.
The point about that it's important to the industry. Can you help me understand what the price differential is between an infant and a 3, 4, and 5?
Oh, an infant's roughly, it depends on some things, roughly $14,000, $15,000. A 3, 4, and 5 is roughly half that.
So that's an annualized number.
Annualized number. So there is, our reimbursement for these vouchers are higher at the infants than they are at the 3s, 4s, and 5s. On the regulated childcare supply side of things, we can see that there's almost 176,000 regulated childcare supply capacity in the state of Indiana. That is down 2% on a year-over-year basis. But I will say that there is, since December of 2024, which is when the wait list started, it is increased by 3%, which is a bit surprising to me. And I think we are, we'll be tracking these as we continue to go over time. I think, one takeaway from our side is that the robustness of at least regulated childcare supply is it's a little bit more robust than maybe we would have thought 18 months ago. And that is, that is encouraging that there isn't, that the correlation between CCDF voucher funding and total regulated childcare supply may be a little less correlated than what maybe we thought it was 18 months ago. And that's good because that means childcare businesses are doing the things they need to do to stay open and manage their own businesses to get to a point where they continue to be open. Here we break this down into our three main types of auspices, centers, homes, and registered ministries. Note of it, let's see, for childcare centers, we're roughly flat year over year. Childcare homes is down 12% from a capacity perspective, and registered ministries are down 2%. We're trying to figure out what exactly, that homes number, we're looking from a parent choice and optionality perspective, from a parent perspective, we are starting to take a look at what does, what can we do in order to, make it easier for homes to exist. And it will be interesting to see as well, as CCDF funding comes back into the system, if we see more childcare homes begin to become licensed childcare homes. This is our childcare programs opens and closed. Just making the point here that there is a natural business cycle in childcare. Between 21 and 24, there was a substantial amount of new funding that came into the space, and as we can see through the opens and closed numbers, there were substantial, programs open, programs closed. In a lot of instances, childcare programs and businesses are small businesses. Year to date, you can see we've had 143 programs opened throughout 2026 and 376 closed. Going back to this slide, on a lag. There we go. A lot of that is in the home space. So those opens and closures are in our homes. And while it is important from a parent choice perspective that there's fewer options in places when homes close their doors, there is, from a total aggregate perspective statewide, it has a smaller effect than whether centers are closing because of the larger enrollment at each place. And now I'm going to hand it over, once the slide deck come up, to Christy Burkhart, the Senior Director of Provider Services and Quality, to go over some things that this office is working on, has been working on over the last few months in the regulatory side.
Thank you, Adam. So just wanted to give a quick update on the rules that have been posted for public comment. Of course, that public comment period has closed. Childcare home and center rule has now been working its way through the revision and approval processes, and we do expect a second public hearing coming up in the next few weeks. We just closed out the CCDF eligibilities, unlicensed registered ministries, and the school age program just this week. So those public comment are being reviewed, and we will move forward with those once those have all been reviewed. And also just wanted to provide a little bit of an update of those services that we moved internally. We've talked about in previous QFR presentations, and that was part of those contract dollars that were reduced, and that work was moved in-house. A quick update is our provider support specialist team has received and worked with 460 referrals over the past 6 months. Those referrals are referrals for coaching, where they're working with programs and on-site and providing that coaching service. That does not include emails to our quality support line or any outreach phone calls that they have completed. And then our child care support line, which is in partnership with Indiana 211, has supported over 13,000 child care calls and child care programs, and have provided over 6,000 referrals to families seeking child care.
On to the last part of this, getting more into the financial side. Because this is the end of the state fiscal year 26, last time we'll see some of these slides in this sort of way. Throughout state fiscal year 26, I alluded to it when Secretary Roob actually wanted me to say something else. We had a cash flow problem earlier this year, which meant that we had a choice. What can we do with our existing contracts? How do we keep the ones that we think are important? And how are we able to transfer funds and our funds to our main goal, which is CCDF vouchers for families? So this list of our contracts, all the ones in yellows are ones that we either terminated, amended, or did not renew during state fiscal year 26. We project that, that's saved us $30 million in state fiscal year 26, and we project it'll save $75 million over the biennium. Those savings went directly to CCDF vouchers. Another way of saying the same thing is looking at this from a staffing perspective. Over the last 18 months, we reduced our contractor staff by 2/3 and our total overall staff by 48% from 413 to 215. And all of that, looking at this from a big picture perspective, we went in state fiscal year 25 from 81% of our expenses going to our voucher payments and 17% going to contracts and grants. We reduced that contracts and grants number to 10%. The voucher payments went up to 88% while keeping salary and benefits constant at 2%. So usually this is where our controller comes into place. She is on vacation, so I get to have the ability I'm going to do this as well. So this is seen this before if you've been here. This is a schematic of how OECOSL is funded. So it is funded through a combination of federal and state funds. The ones above the dotted line are the federal ones. The ones below are the state ones. So predominantly and historically, the funding has come from the Child Care Development Block Grant from the federal from the feds. And then also the state of Indiana also allocates TANF funds to fund child care vouchers. Per federal regulations around TANF, states have the option to transfer up to 30% of the funds they receive from TANF to put it into child care vouchers. We do that, and we do that in the state of Indiana. It has been a longstanding policy within the state of Indiana. And know that we are unique in the country that doing that. It is us and one other state that do that 30% transfer. We also put $25 million of TANF working families into child care vouchers for families that qualify within that program. On the state side, the two budget lines from a state perspective are the early childhood learning line and the pre-K education line. The early childhood learning line, that $31.1 million, $4 million goes to effectively our federal match for us to pull down all of our federal funds from the CCDBG fund. And then the pre-K education, that $26.1 million is unleveraged state dollars that goes to fund the On My Way pre-K program. And then one-time state funding, CCDF hold harmless, was a long time ago. During this current biennium, the state appropriated $147.25 million to fund child care vouchers. We have used that.
Okay, so can you flip back to the last slide?
Yep.
So that's a 2026 funding mechanism.
This is the 2026 funding mechanism. In at the next one of these, there will be another box down there for the $200 million of frog funding. The overall financial summary here for OECOSL. This is all of our programs and funds aggregated into one. Our actual year-to-date expenditures for the state fiscal year was $411 million. $352 million of that was the line social service payments. That is for CCDF and On My Way pre-K vouchers. And the only other thing that I would note on here is the line 3 external services expense. That is The difference between actual and budget is what we did on the cost containment perspective. And this is a different way of looking at it by fund and by program. It's obvious our largest program is the Child Care and Development Fund, or CCDF fund. We spent $371 million in that. The On My Way Pre-K is the next one, as I mentioned earlier, that is all state dollars that funds that program for 4-year-olds. And then the other ones kind of, the preschool development grant just is because Lisa mentioned it earlier, that is for our, that fund is, that line there is for our completed grant that ended at calendar year 2020, at the end of 2025. Down at the lower part, our sources of funding, state funds, we spent $195 million in state funds this year. That is effectively, think of it as our state appropriations for the early childhood learning line and the pre-K learning line, and then also coming and also seeing that spend of that CCDF hold harmless happened in almost all of it happened in state fiscal year 2026. Federal funds has had $215 million spent. So this year, the state fiscal year ended up being a little bit different than it has been in historical years. Usually from a perspective of proportion of state and federal funds, state federal funds this year were 47% of these programs, and then federal funds were 53%. In most other years, that has skewed very heavily to federal funds, something along the lines of 70 to 80%. Here's some detail we'll go through our two major funds here, the Child Care Development Fund. This just breaks out some of the things that for this specific fund, total expenditures were $371 million. And then down the funding, break out how that's funded, right? And in this case, it's about 50-50 state versus federal. And then our other major program is the On My Way Pre-K Fund. We spent about $11.5 million of a $23 million budget. That comes from us. We projected that we had funding for roughly 2,500 On My Way Pre-K vouchers last enrollment. So during June, July, a year ago. As I mentioned earlier, we did not hit that number. So that leads to that variance in that lower number, which causes the actual state fiscal year expenditures to be less than what we projected. And then down at the bottom, that shows, just note that the On My Way Pre-K program is a state appropriation and funded program. We got some other, and if as part of the presentation, I will not go over them, as our non-subsidy funds very quickly, just to mention them. This is the Preschool Development Grant Fund. This is closed out. We are very close to actual versus budget. We have a School-Age Childcare Fund. This is a fund that's state appropriation that is used to fund grants for school-age programs. Long-standing program. It's something that we put out grant, we have a grant application, a lot of grants, but usually between $20,000 and $40,000. And then our Head Start Fund, there's a small amount of funding for Head Start. And then we get a small amount of money from the Social Services Block Grant, $170,000, and this is our Child Care Licensing Fund. Line push. There we go. That is it. Who has any questions?
Thank you. We have not received any questions online. A reminder, you can still ask questions and you'll receive answers in writing at the askthesecretary@fssa.in.gov email address. We will now be taking a 15-minute break and will return at 10:45 for the Division of Mental Health and Addiction. Thank you. Okay, thank you for joining us for the Indiana Family and Social Services Administration's quarterly financial review. We will now begin with the Division of Mental Health and Addiction. as they're getting there, a reminder, if you have questions, you can email them to the askthesecretary@fssa.in.gov email address, or we have, if you're in the room, we have note cards back here. You can fill it out a note card as well. And those questions will be read at the end of their presentation. Thank you.
Good morning. I'm Sarah Sailors, Director for the Division of Mental Health and Addiction. And with me today are some new faces. So Mark Loggins is our Division Director for Addiction Prevention and Recovery. And then Edward Kai is our new Controller for DMHA. And then, of course, Katrina Norris, who's the Deputy Director for our state hospitals. DMHA sets the care standards for the provision of mental health and addiction. We ensure clients have access to the quality services. We certify all of the community mental health centers. We designate catchment areas for those centers and for our certified community behavioral health clinics. We operate 6 state psychiatric hospitals, 2 of which serve youth and 5 that serve adults. And then we provide funding support for the mental health and addiction services for those populations with a financial need, and we administer federal funds. Through our key program areas, which include our CMHCs, our CCBHCs, and our block grant recipients. In state fiscal year 23 through the end of June, we had served just over 122,000 adults, 56,740 youth, for a total of 178,908 individuals.
So are those unique adults?
They are unique adults in your total numbers, and then in your month numbers, they are unique also, but they could be in multiple months.
So if you foot it, if you added up the youth, right, you would not end up for the year, you would not end up anywhere near 56,000, right? So they're unique individuals at the total,
Yes,
right? But not but you
Correct.
could receive services in January and in March.
correct.
And then looking at our financials here, for all the financial tables today, this is year end, so there will be no forecasts. Starting with SMI, we had an overage in the payroll, and part of that issue you'll see is coding issues. That's something we have addressed and that should be fixed in SFY 27. And then going down to the total expenditures, we ended up having a little over $14.5 million in under budget. Part of that is due to our MRO and CCBHC and our intergovernmental transfer that came out of a different area, that's Community and Mental Health Fund. And then as working part of the state fiscal year 27, we're ensuring a more accurate forecast. And then moving to our seriously emotionally disturbed financial summary. Again, payroll was an issue, but overall the variances have leveled out. And again, on this fund, in this program, we have came under budget this year.
There we go. So we are about 18 months in to the 4-year demonstration for our certified community behavioral health clinics. We have 8 agencies providing 9 core services across 40 counties. We've talked a lot about this model over the last 18 months, but it expands services for Hoosiers. It includes crisis services, which are offered 24 hours a day, 7 days a week. We do have 21 required metrics that we're using to help shape this service across the state. And then we also are really engaging in making sure that we are serving both mental health and substance use disorder. This slide here shows us a comparison from calendar year 25 to the first 6 months of calendar year 26 for our clinic collected measures, which account for 11 of the 21 metrics I just mentioned. So we're seeing improvements in compliance with screening and follow-ups in year 2 compared to the year 1 data. The green highlighted on the far right side, shows us where we've seen those compliance improvements. Some of these might seem small, but I think others are very significant, especially when you're looking at like the screening for suicide. You'll see that youth went from 55% compliance to a 62% compliance. And then our adults went from 74% compliance to 90% compliance. We're also seeing a 4-day reduction in the time to initial services. And I think this is really important because we know that the earlier people engage in services, the more likely they are to be engaged in their overall care and stay in those services. Before anyone asks the questions, I would like to point out one of the places where you see a significant decrease in our social drivers of health. And I think this metric is a little bit slightly misleading because it is a blended measure. So it measures not only new patients who are coming into services and making sure that they get their screening right away, but it also measures ongoing clients who then need to have that measure at some point in time during the course of that year. So when you look at our initial clients getting that screen, we're over 90%. But the clinics have an additional 6 months to make sure that they get the ongoing clients their screen. So I think as we watch this metric month over month, you should see better compliance as we get closer to the end of the year.
Okay, let me ask a couple questions because I don't think I've seen this chart before, which is fine.
Surprise.
Have I?
Well, maybe Paul shared it with you.
He's holding out on me again, sir. The number on assessing, you mentioned assessing for suicide risk, it says it's through 7/14. But
Correct.
okay, so that number so that would mean that if that were timely data, that would mean that we are going to have 7,000 as opposed to 20,000 completed screenings. So that doesn't seem quite.
They screen at almost every service, I think, for the youth. Like it's a multiple time screen versus a one time a year screen.
Right, but the 2026 number looks suspiciously small for 7 months and 14 days of 2026 as opposed to where we are in 2025. Right, so
Yes, yeah.
So I guess my point would be, I doubt the number is actually through 7/14. That's what was reported to you by 7/14, but other people have, the polls have closed, but the returns are not in.
Yeah, I'll follow up with Wendy and check on that.
The other numbers don't seem as odd as that one does.
Fair. Any other questions? Good.
Probably, but I'll let you go.
So most of you are probably aware that we have 3 national 3-digit numbers that provide 3 types of help. 2 of those numbers are actually administered within FSSA. So our longest standing three-digit number, and probably the one that's most recognizable to everyone is our 911 number. And this number's been around for 58 years. It's for medical emergencies, fires, crimes in progress, something that requires immediate physical intervention. And so when you think of this number, you think of lights and sirens. We also recently celebrated the 4-year anniversary for 988 in July as being a national number, three-digit number. This number is administered within DMHA. It's this number is for any form of emotional distress, thoughts of suicide, or mental health or substance use crisis. And then also administered by FSSA is established 26 years ago, I believe, is the 211 number. And so it's designed to connect individuals to essential community resources like food, housing, utility assistance. All three very important numbers, but all three serve a different type of help. In July, we finally launched our public dashboard for the crisis continuum. So you'll see this dashboard is live on our website. It is inclusive of all three pillars of the crisis continuum. We did begin collecting data in June of 2023, so you can toggle different dates and go and see the data by dates, by providers, by catchment areas. It's very interactive. You'll see when you look at the data in Pillar 1, so that's someone to contact. Indiana received over 315,000 calls during that 3-year period that we've been collecting data. In June of 2023, when we started collecting, we had 2,873 calls. And then June of 2026, we had 13,017 calls to the 988 line. Pillar 2, someone to respond. So Indiana has had over 13,894 mobile team dispatches over the past 3 years. 84% of those were for adults and 15% for youth. In June of 26, we had 1,345 mobile crisis dispatches. And then Pillar 3, which is a safe place for help. During our 3-year period, we've had 22,275 visits to our crisis receiving stabilization units. In June of 26, we had 1,719 visits. And then I would encourage all of you to visit our dashboard and look through that data more intentionally. This here you've all seen before. This is really just a visual map of all three pillars of our crisis system. So we have 3 contracted providers who are answering our Indiana 988 statewide line. We have mobile crisis teams in all 92 counties. And then this also depicts our 24 crisis receiving stabilization sites across the state. Not very good at this. There we go. Okay, a little bit more nuanced data around our 3 pillars. So this is comparing April and May of state fiscal year 25 to April and May of state fiscal year 26. So Pillar 1, 988 calls show the increase in volume, with the dotted line being our in-state answer rate. So if our in-state call centers are unable to get to that call timely, it routes to the backup line. We want Indiana, we want Hoosiers to be able to reach someone in our state. So it's, I think it's exceptionally well that our centers perform so highly, and our in-state answer rate is 97%. Pillar 2 is our mobile responses, which shows the increase in dispatches with that dotted line being the number of unique individuals who receive a mobile crisis. So you'll see we have about 80% of individuals who are unique individuals, meaning that 20% of those who receive mobile crisis response need to have a second response. And then in pillar 3, somewhere to go shows the overall visits staying relatively stable over the past year, the dotted line indicating the number of unique individuals who are accessing the CRSSs. 72% of those we serve are unique individuals. And then the nice thing about having the public dashboard and it being interactive is I could go in there and look at, well, how was the system performing when we first started, right? And so I was able to see that when individuals were using the crisis receiving stabilization services, our unique number was much lower. We were serving only 60%. So 40% of individuals were having to have a second or third, right, time visiting the center. So I think that shows us that over time, we are actually stabilizing individuals as we're now in the 70%. And I hope to continue to see that increase as individuals then engage in ongoing services after they've had a crisis response.
And looking at the 988 crisis system financial summary, we came in budget with most of the items, except for obviously our largest category, which is the external services expense. Part of the reason why we went over is timing of billing, especially towards the end of the year. We got billed heavily in July of Q1.
External services, what's the delta there?
I believe it's contracts. Yes,
Okay, operational contracts or capital?
operational.
So we would expect it to be a similar number in 27.
Correct. Yes.
Yes, but we did recently change how we're contracting with those centers. We went from 5
Right.
centers down to 3, and we, the 3 centers also have to now do the text to talk portion. So they are a little bit different. Am I on the wrong slide?
No.
Okay. Next slide.
Yep.
All right, this next section here is going to be about the addiction and state opioid response programs that we have here at the state of Indiana. This mixture includes the state opioid response grant, which is a discretionary grant we receive from SAMHSA on a yearly basis. Also state treatment funds that are given to us by the legislature, and then also the Substance Use Prevention, Treatment, and Recovery Services Block Grant, or SUPTERS, as I will be referring to it from now on. It's a long, long name. But some of the key programs we've identified that we're going to share, as we've shared in the past, are about providing treatment for folks without a third-party payer for substance use disorder, as well as recovery resident stays for people without a third-party payer. Overdose Lifeline purchases and distributes doses of naloxone to laypersons and community partners. And as well as other programs, including lift rides administered through Indiana 211 to provide people to transportation to treatment and recovery appointments. This is a slide detailing the numbers served for a couple of these programs, including the lift rides. We saw 8,400 lift rides in Q4 for a total of 19,757 total for state fiscal year 26. Also, the unduplicated number of participants in our recovery residences funded by the state opioid response grant. The DEBS acronym is just the DMHA electronic billing system that we use to administer these claims. We saw 592 total in state fiscal year 26, as well as 1,700 people receiving treatment services at various clinics, OTPs, throughout the state who do not qualify for Medicaid and have a financial barrier. Also of note, 317,000 doses of naloxone were purchased distributed by Overdose Lifeline to various community partners across the state. So one of the programs that we decided to highlight today was the Mobile Integrated Response System, or MERS. And I was lamenting backstage that it is not a great of a acronym as frog or toad, but we will work on that in the future, I promise. MERS, Mobile Integrated Response System, or MERS, is a community-based peer-led model bridging the gap between crisis and long-term recovery for Hoosiers with opioid and stimulant use disorders. It is 100% funded by the State Opioid Response Grant. We launched it in 2019 with some supplemental funding from SAMHSA. Currently, we have 11 teams operating throughout the state, present in 40+ counties, serving both urban and rural areas. This program has gotten some recent interest from SAMHSA and some of our national partners. Sarah had the opportunity to present on this at a NASDAD meeting to her peers back in April, and I will have an opportunity to present this program later this month at a SAMHSA conference about coordinated overdose response across the nation. This MERS was birthed before we had 988 or mobile crisis teams. So this was really a innovative project to really shepherd people from vulnerable points in their lives to a point in recovery. It is not meant to be a crisis service. This is a service that involves helping people, up to 72 hours perhaps after crisis. And that's not even the only outreach population. As you will see in subsequent slides, these teams who are peer-driven, peer recovery support specialists are the mainstay of these teams. They can meet people in any number of settings to shepherd them through the recovery process. Just some highlights on some places where people are served: emergency departments of hospitals, jails and courts, recovery residences. There are street outreach initiatives, as well as community events where these teams that are led by peers, again, really meet the public where they are and do that outreach. It really expands the reach of peer recovery to folks who may not generally be exposed to that in the traditional recovery settings and traditional treatment settings. And we see a lot of secondary beneficiaries, from families and loved ones to hospitals and EDs. We do have some outcome data that will show that this does reduce the amount of ED visits and recidivism. This is data from SFY 25, federal fiscal year 25. We are compiling the data for federal year 26, as the State Opioid Response Grant operates on a federal fiscal year, since this is a federal grant. But in federal fiscal year 25, we did see 5,700 referrals from community, jail, and emergency departments. Over almost 6,500 unduplicated people were connected to a peer recovery coach for over 27,000 encounters. Some of the outcome measures that we got from a 2023 evaluation, which we are hoping to update in the coming years. National outcome data saw that we had a 35% increase in abstinence from drugs and alcohol, 50% reduction in emergency department visits, 38% increase in stable housing, and a 50% increase in employment and school attendance as a result of people participating in the MERS program in their various areas. Our numbers for federal fiscal year 26 look to be on par and to either meet or exceed these figures you're seeing for federal fiscal year 25. And we are looking to do a refreshed evaluation in the coming year to update these numbers to track progress.
Or can you come see me on the last slide, or these mirror slides prospectively, and help me understand how it dovetails into what we're doing with CCBHCs?
Yep.
And this is just a map showing the coverage area. Again, these are grant-funded programs. And we are pleased to see the expanded coverage of these programs across the state. There are referral lines on here. One of the goals we have for the next year is to integrate these MERS teams into the 211 so that when folks are looking for community referral, they don't have to remember a 10-digit number. That 211 is obviously a better option going forward. But these MERS teams also do get referrals through community partnerships. So this warm line that most of these teams have is not the only way they are getting contacted. Community partnership is definitely a strength of the MERS system. And it is definitely how people get access to these services.
And then looking at the substance abuse treatment financial summary, one of the biggest numbers that jumps out is the variance in the social service payments. We're for this year and for the new fiscal year this year, we're looking at adjusting some of this numbers so that we won't be over in the social service payments. And then overall, though, from say year fiscal 26, we ended up at $4.1 million under budget.
The next program we're going to be talking about is our problem gambling program. The funding comes from admissions and supplemental wagering tax and a portion of sports betting tax revenue that are deposited into the Addiction Services Fund. We currently have provider agreements with 14 agencies that offer problem gambling treatment and education services. We also administer a toll-free gambling helpline that is mandated in statute, and provide oversight of statewide partners that address problem gambling issues. Some of the data here will show that we saw a 741 number of unique clients served by problem gambling providers, as well as 176 new internet self-restriction program participants. That way folks can be barred from participating in online gambling.
Okay, so before we get off problem gambling, I don't know what percentage of the gaming and other prediction are going to Couchy and other things that weren't contemplated when we started doing this. I think we need to think about, you guys need to, because I'm not going to do the thinking, you guys are. So I'm not going to use we, but do we need legislative changes at the state level on regulating on how we deal with the what amounts to betting, right? Because you can bet on, how long Sarah's going to talk today, right? On Couchy.
Actually, if you want to go a little bit.
Under over.
So I that's a question which I don't have an answer to, but let's think about it.
Absolutely, yeah. Prediction markets definitely are an emerging factor in the world, and definitely a loophole that I think some have found, and I think some more thought and some more policy can be done around that.
And then looking at the gambling financial summary, not a lot of variance here. And then we did come under budget in this at $968,000, and pretty much on track. Then looking at the substance abuse prevention financial summary, again, payroll was a coding issue, but overall, we hit our targets and we came under budget at $3.1 million.
All right, now on to opioid settlement. So this is Indiana is going to receive more than $980 million from the National Opioid Settlement over the next 18 years. This includes a 50-50 split between the local the local municipalities, the local units of government, and DMHA. Abatement funds have to be used for approved uses, and unrestricted uses are do not have to necessarily apply to those Exhibit E restricted uses. And it is all posted onto the Indiana opioid settlement website if you want to go further into the details of the opioid settlement arrangements. Sarah and my boss Kelly went to the state budget committee and got the next 2 years of the opioid settlement plan by DMHA approved. Some of these initiatives include prevention, treatment, recovery, workforce, and enforcement. The plan should be posted onto the opioid settlement website if you want to go look further into what these dollars are going to be used for. We are also looking forward to partnerships with DCS, the Department of Health, and the Indiana Housing and Community Development Authority.
And then within the opioid settlement financial summary, most part came in within a budget here. There is some variance with the social service payments. Again, timing of billing and when those forms are getting submitted and when they get paid out. And then we did end the year with a $9.1 million extra underspend.
Next program we're going to highlight today is the opioid treatment programs, otherwise known as methadone clinics. We have 26 DMHA certified opioid treatment programs across the state of Indiana. These clinics have to comply with three state and federal laws and bodies, including SAMHSA, DEA, and the Board of Pharmacy, and they have to hold an accreditation from a national recognized body. Here is just a map of where these opioid treatment programs are located. And here's some data about the reach of these clinics. We saw 14,817 unique people served in state fiscal year 26, and a pretty even churn of admissions and discharges throughout the year at those clinics.
And on the opioids treatment programs, methadone clinics, financial summary, we're within variance. There isn't a whole lot of, we didn't go over really a lot on the expenses or the ID bills, and we did come under budget at $40,000.
Moving on to our Recovery Works program. So this is a program designed to divert low-level offenders from incarceration into community-based services. It was launched in 2026 through House Bill 1006. We have a state appropriation of $12.5 million for these services. This funding supports traditional services like traditional treatment models such as mental health counseling, substance use groups, and then intensive outpatient programs. We also support alternative types of approaches such as peer support in our jails and then the faith-based treatment options. We had 2,249 newly enrolled individuals in Q4. Our recovery community organizations began to bill this year for incarcerated services per individual, where historically they were paid through a contract. So we've changed this because we feel like it's much easier to track the number of individuals that they're actually serving. And then you'll see in our UIndy partnership, which UIndy has changed their name, so you will also hear it called Second Chance. And so UIndy has expanded its reach. This is a program that's designed in some cost sharing. So the state has a portion of the dollars, Unite Indy contributes, and then employers also participate in this. We're serving many more counties and attracting more employers to this program. And so in Q4, we actually had 180 individuals who participated with 35 different employers.
And looking at the Recovery Works financial summary here, We did have a big variance in the social service payments, but we also had a underspend in the external services expense. So something that we, for us, the state fiscal year 27 to keep that in mind and adjusting. And then we did end up spending about $44,000 over, and part of that again is the billing and when they come in. Over to the mental health recovery funds recovery. It's a fully federally funded fund, and on this one we went over by about 300,000.
Within DMHA, our quality assurance and quality improvement team audits our community mental health centers, our addiction service providers, private mental health institutions, and our recovery residences. The team received and reviewed 185 complaints from our consumer services line. The team also received and reviewed over 800 provider-reported critical incidents. Across all of our program areas, we conducted 81 site visits, issued 40 corrective action plans, and 11 providers went on conditional status. Some of the trends that we saw during this quarter were staff providing services without the correct training credentials, lack of signatures on treatment plans, no releases of information for external contacts, lack of appropriate assessment of needs, diagnostics, and risks, and then lack of safety or relapse prevention plans. So when when we find these, we put them on corrective action plans. We also provide technical assistance to help improve the quality of those services so that they can stay off of corrective action plans and provide better quality to our Hoosiers.
And looking at the DMHA,
Sorry, I went one. There you go.
thanks. On looking at DMHA admin financial summary, we did have a big variance in the payroll, and part of that is, again, coding that to the right places. That is something we want to fix, and because it was coded to the wrong places, we did have about $650,000, under budget, but we're hoping in state fiscal year 27 to be closer to zero.
Slide is just a quick glance at our overall staffing. So in June, we had 84 FTEs as state employees, just slightly down. And then we still have five contracted positions.
Then on this slide, this is a summary of all of, not all, but the big major DMHA contract summary here. And as you see, Indicare and our CMHC and CCBH providers are our largest and on track. And looking at our DMHA financial summary, we did, this again, tables just sums up all the other financial tables. Overall, we did come under and at $32 million, and we're well within budget. And this is just a breakdown of the federal share versus the state share, how much we've spent in state fiscal year 26.
Good morning. I'm Katrina Norris. I think I know a lot of you in the room. So just going to walk through our state fiscal year 26 Q4 review here, our normal metrics, financial performance, and ongoing system transformations. This slide, you can see that we have had an increase in the patients that we served. 116 more patients were served in this state fiscal year than in the previous. This is our metrics on occupancy across the network. So obviously occupancy levels remain extremely high at nearly all of the hospitals. The overall network occupancy is at 90% for Q4. This continues to place pressure, obviously, on throughput and discharge planning, as well as referral management.
Yeah, Katrina, I would just, if you took out the EPCC, the children's place, it would be, that 90% number would be much higher than that.
Yes.
So, I mean, I think that's the real question, which is where at a very high level. here.
Absolutely. There it goes. It's a little sticky. Okay, as far as wait times, again, our wait time metrics show that persistent strain across the admission pathway, with the consistently elevated length of wait across the facilities outside of the Children's Center, as noted. But keep in mind, this is an average for all patient populations at those individualized locations.
Okay, it might be helpful if you can to break this wait list out into the forensic population
Sure.
and the seriously mentally ill population, because I mean we're trying to drive home the point here that the forensic population has, I mean, you talked about ongoing system transformation. Well, that explosion in forensic beds has transformed our system, but we didn't do it, right? It was done to us by the courts, and is significantly changed from my first tour of duty. So
You're taking the words right out of my mouth, Secretary.
I'm just reading your mind.
We're in tune. So this is really a capture of what we were just, excuse me, discussing on the adult patient population side, showing the admissions in Q4 for our adult populations, as well as who we are currently serving. The civil admissions remain much smaller, a much smaller fraction of our overall volume, because those forensics admissions continue to dominate both new admissions and our current census. This shift has shaped nearly all of the operational and throughput challenges, as we've discussed many, many times this year. So I'm excited to show you some more about the efforts in the competency crisis in later slides today. This is our monthly or our quarterly review of staffing. Our state staff have remained stable in the mid 1,500 range, holding steady through Q4. Contractor staffing has fluctuated a little bit, generally increased to help support some of our critical operations and our highest pressure points. Unfortunately, as a network, we are feeling the strain of a serious nurse shortage again across the network and competing for that nursing staff. This is our contract summary. Again, the larger contracts, the major contracts for the state hospital network. Obviously, contract expenditures remain on track. Cura Hospitality continues to represent the largest operations contract, as they're our food service provider for 5 of the 6 hospitals. Most vendors are showing strong remaining balances and aligned with projections spending through the fiscal year. This is everyone's favorite slide. I feel like we've talked about a great deal, so I will not belabor that point. We continue to struggle with those incompetent to stand trial referrals. The number of ICST referrals has grown, obviously. That trend is not slowing. As of July 16th, when these slides were designed, we were already at 416 orders for this calendar year. So the demand is far greater than the statewide capacity. This is what I was excited to share with you, because we've talked so much about the competency crisis. So I really wanted an opportunity to illustrate the human side of this crisis and walk you through David's journey here today. His experience, this fictional experience I'm giving you, really mirrors a great deal of the individuals that are navigating through both the mental illness and the criminal justice systems when deemed incompetent to stand trial. Keep in mind that individuals like David cycle repeatedly through law enforcement, jails, courts, with little stabilization as the competency pathway does not meet the needs of these low-level nonviolent offenders. So David, this is my fictional character here, just to give you a snapshot to a very large percentage of the referrals we are receiving. 23-year-old male, born and raised in Indiana, had a standard upbringing, is a high school graduate, but recently began having some stress and mental health issues, including private episodes of psychosis. And when you have private episodes of psychosis, that oftentimes causes your family and your supports to withdraw. He's never had services before. And as a result of this, he has experienced a loss of his job, can't afford his basic needs, and is on the verge of homelessness. This slide was designed for the original state in circa 2019, give or take. So I like to call it the original state of the competency crisis, where we really started to deep dive into some solutions. So these are historical wait times on this slide. And at times, Hoosiers were waiting sometimes up to 9 months for that evaluation and 4 months for a state psychiatric hospital bed. You can imagine the sheriffs were not very pleased with those timelines at that point. At discharge, they would often return directly to the jail without medication continuity or community support. And ultimately, when they went in front of the judge, then they had a time served sentence and they were released with no supports to the community. So what we would like to do is show you the vision for the future, because a lot has changed over the course of time. We have made some meaningful improvements in several areas, including the competency restoration wait time being decreased from that 4 months to approximately 40 days or less. Please don't forget that it has led to a bed shortage for civil patients. But what is really, I think, important here today is we've expanded our engagement with the courts, with the jails, with local law enforcement agencies, and improved how cases were coordinated. We've worked diligently with discharge options and improved planning with community organizations like our community mental health centers and our CCVHC partners, so that they're aware of forensic clients that will be returning to their home communities. This is where we want to be. This is the vision slide. And the vision is where individuals like David, those low-level nonviolent offenders, can get support much earlier and perhaps prevent their intervention or their entanglement with the criminal justice system. Mobile crisis teams to respond. That is huge. But in addition to that, if they are arrested, courts to divert, and courts having the ability to divert to outpatient treatment options in lieu of raising competency, evaluations to occur very timely, because the longer a person waits, the greater the risk for decompensation and the greater the risk for the medication management to be much more detailed. Discharge to be very supportive, very intentional, use of peers in jails, for example, to align housing options, and again, that medication continuity and person-centered care. That's where we want to be as a state. Slide move. Competency restoration within the state psychiatric hospitals denoted here on this slide. The hospitals continue to carry the overwhelming majority of competency restoration volume, with more than 400 active patients in some months. Restoration numbers remain high, demonstrating strong clinical throughput despite the rising demands. And these teams have worked really hard with minimal resources at times to keep up with this volume. They are required to do a report to the court at the 90-day mark. They're also required to do a report to the court at the 180, according to statutory obligations. And these are not just quick reports. Our clinicians put in a great deal of time and effort to ensure the court is well informed on those patients. And since the volume is so problematic, you also know about Project Create, which is our additional inpatient competency restoration capacity that we contract with Hendricks Behavioral Health. The program continues to grow with admissions and discharges increasing through Q4 as contract amounts were adjusted to reflect recent changes. And this is the overall hospital network financial summary. So total year-to-date expenditures were at 191.9 million, which is slightly under budget. Can we just pause for a second? Okay. That felt really good. The hospital teams did a really nice job this fiscal year. And again, if you're curious about that little blip of red there in the NDI, excuse me, they do a lot of volume and a lot of short turnaround. So in layman's terms, look more like an acute care, although our length of stay does not indicate acute care, as opposed to the other locations, maybe taking some more complex cases.
Katrina, can you just pause for a moment and talk a little bit about the changes that you made in operationalizing to get those services from an administrative standpoint?
To get to this slide?
No, to get to the change, because you centralized a bunch of stuff, you made a bunch of changes to get inside your budget, and I don't want you to hurt your shoulder patting yourself on the back, but just a little discussion of it would probably be insightful.
Well, I really can't take the credit for that. It is the hospitals at the local level that bear this burden. And certainly they have been good partners as we began shared service models, in things like information technology services, staff development. We've done a lot of work with sharing resources and not being siloed entities. And so those efforts helped us to align cost, more efficient processes. And again, certainly the local level leaders did, they did the work for it. So I'm not going to take credit for that, but thank you for acknowledging that. Also, with our allocation from the General Assembly, we are fortunate that we can move funds around. So if one hospital is a little bit off, or maybe they need some additional contract, say physicians, that we didn't know they were going to need when we did our budget planning, we can move funds amongst the hospitals to level those out. And that's a nice flexibility that we have. But overall, the network is performing within acceptable fiscal parameters. And again, kudos to my staff. So here's the breakdown. No surprise again, salary and benefits are the largest portion of our total cost. Overtime, contractors, food services, meds continue to rise with the census growth and the acuity. I just saw a national report and about the complexity of the forensic referrals coming in. And when I say complexity, I'm not only talking about their psychiatric symptoms, but serious medical conditions. And oftentimes we don't know that information until they arrive at our hospital. I will just give you an example. We had an individual arrive with a gunshot wound. And he had not reported that at intake at the jail. So when he shows up at our hospital and we do a history and physical, now we have to pivot and care for that gunshot wound that we were unaware of. And those are very costly expenses that we were not ready for. So I think we can anticipate in the coming state fiscal year, obviously expenses are going to continue to increase in the areas of food and medication, staffing, things of that nature. But I'm really, again, very, very proud of my teams and all of the cross collaboration efforts that have happened. We have worked very, very closely with the Office of Court Services and the Supreme Court's Behavioral Health Office to really be good partners in making these transformations. In addition, we've worked alongside the CHAMP work group, which is the Children with High Acuity Needs Project, with a multitude of stakeholders to make pathways and throughput easier for youth with serious emotional disturbances. And we're going to continue to collaborate. We've done a lot of internal bed allocation and throughput improvement projects. The medical directors meet frequently, monthly, to talk about those beds that can turn, if you will, functional versus non-functional beds based on length of stay. And these partnerships are just so essential to managing the statewide forensic pressure, as well as improving the systemic flow for Hoosiers of all ages with severe mental illness or serious emotional disturbances. In summary, here today, while the demand, particularly the forensic demand, continues to grow, our network remains disciplined, responsive, and fiscally aligned. We're making measurable improvements in the competency restoration strength by these collaborations, and we're strengthening partnerships that will help reshape Indiana's behavioral health and justice systems.
Can you outline for me when a patient is sent to us from a county prison by a judge, right? What's the average cost?
Approximately $1,000 a day.
And what's the average number of days?
That depends, usually around 100 though, give or take.
So, and that, of course, we leverage federal funding for that, don't we?
No, we do not
I
leverage.
mean, we're spending $100,000 in state taxpayer money every time a judge sends somebody to a state hospital?
That's correct.
And we anticipate they'll send, looked like, over 800 folks this year.
Yes,
So that would be $80 million in general revenue fund money that we're spending on competency.
correct.
When we deal with the incompetent to stand trial patients, how much time do we spend dealing with their underlying mental illness?
Minimal.
A minimal amount?
Medication management primarily, but our order is to prepare them for trial.
So we're not really helping them to get them any better. We're just preparing them for trial for $100,000.
Correct.
All right, just want to make sure that I was clear on that.
You're clear.
That it? I think we're ready for questions.
Thank you. We have one question from Jason McManus, President and CEO of the Wabash Center. What percentage of individuals needing or occupying a forensic bed at a state hospital have a documented intellectual and/or developmental disability?
That's a beautiful question. Thank you. Ironically, I just might happen to have some information with me because I misfiled this morning, and I had a document that I was researching for another project. Again, one of those ongoing collaborative cross-agency discussions. So I do have some information here about individuals that are incompetent to stand trial. We call that ICST adjudicated, which means we've had them 180 days or less. And this report from misfiling is a little bit old, but at that time, there were over 100 individuals with a documented intellectual disability in our care.
Okay, thank you. That's it for questions. We will now take a break for lunch and we'll return at 12:30 for the Office of Medicaid Policy and Planning. Thank you for coming to the Indiana Family and Social Services Administration's quarterly financial review. Our day picks up now with the Office of Medicaid Policy and Planning. If you have a question, you can send that question to the Ask the Secretary at fssa.in.gov email address, or we have note cards back here that you can come and fill out, and we'll ask those questions at the end of their presentation. Thank you. Actually, as they're sitting down, if anyone lost a diamond earring, we have it back here. So if you lost a diamond earring, I'm certain it's not Secretary Roob's. So if it's someone else's, please come back here. The earring's back here.
How big?
It's a diamond earring, yes.
Good afternoon. Welcome to the Medicaid Quarterly Financial Review. There you go. My name is Lindsay Lux. I'm the Chief Operating Officer for Medicaid. Today, I'm going to be highlighting work requirements and also the Medicaid administration budget. Joining me on stage are Medicaid Director Audrey Frenzel, who will be highlighting our Rural Health Transformation Program, Director of Reimbursement and Actuarial Services Kathy Leonard, and Leslie Melton, our Controller, who will be reviewing our Medicaid assistance budget and funding, and Katrina Etter, our Chief Clinical Officer, who will be reviewing maternal and infant health metrics. I know Secretary Roob will be speaking about work requirements in his presentation, and if you were here this morning, you also heard DFR Director Sunshine Beam speak about work requirements, but you really can't hear about this too much. So I wanted to start today just by saying what is a work requirement, and the work requirement is that an individual must demonstrate $580 of monthly income, or they must demonstrate 80 hours of collective community engagement, which includes a work program, work, educational programs, or community service. Legislation identifies specified excluded individuals. These are individuals that are not subject to those work requirements. The individuals include former foster care youth, American Indian or Alaskan Native, parent, guardian, caretaker, relative, or family caregiver of a child 13 years of age and under, or of a disabled individual. Disabled veterans, medically frail, those already in compliance with TANF and SNAP work requirements, a participant in a drug or alcohol treatment program, an inmate of a public institution, or an individual who is pregnant or in their 12 months postpartum. In addition to specified excluded individuals, there are exceptions. An exception is different because it means that the person is deemed meeting the work requirement. And those individuals include anyone under the age of 19, anyone receiving Medicare, anyone who is not an expansion adult, or individuals incarcerated within the prior 3 months. I want to highlight resources that we have put together and are available to you today. We have information for members. We have a partner toolkit available. Here are the websites you can take note of. But what I really want to stress is if you do interact with members, what can you do to help them today? And that is to ensure that they have an FSSA benefits portal account. That account is where they can ensure that their contact information is accurate. They can make sure that they understand what those work requirements are, and they can opt in for electronic notices. We recently, during the month of July, sent a notice to every person who is subject to these work requirements, but they can also opt in and get them here in the portal. You should continue checking these resources. We will be updating. We will be posting more information as implementation nears January 1 of 27. Next, I will turn it over to Audrey to talk about rural health transformation.
Hey, good afternoon, everybody. As Lindsay mentioned before, my name's Audrey Frenzel, and I'm Indiana's Medicaid Director. Wanted to cover some of the rural health transformation project that I would assume most of you are probably familiar with. But if not, in the winter of last year, we, FSSA and the Indiana Department of Health, submitted a joint application to be able to participate in the Federal Rural Health Transformation Project. We had requested $200 million, but because of the competitive and innovative nature of our application, we were awarded an additional $7 million on top of that. I think, important thing to call out about that $207 million is that is for the first year of the Rural Health Transformation Program, and it's imperative for the Department of Health and FSSA to spend those dollars in year one in order to continue receiving that same amount of money for the following 4 years. The breakdown of the $207 million for year one is a 60-40 split between the GROW regional grants and then the 11 statewide initiatives that Department of Health and FSSA have identified. And the GROW regional grants, the state was split into 8 regions, and those regions collaborated together to submit an application of how they would be spending their dollars. Really quickly, just some of the highlights of the Rural Health Transformation Program. Really, the goals and opportunities here are in alignment with the federal initiative to make make America healthy again, but specifically rural America, and how we're applying that here in Indiana. Okay, as I mentioned, I might have gone 1, 2, there we go. As I mentioned before, the state was broken up into 8 separate regions that really focused on the unique properties of that rural community. And we saw hospital systems, community partners, advocates, different stakeholders come together over the course of the last few months. Those applications were submitted to the Department of Health and FSSA in the beginning of July. We had a working group that spent the first week of July reviewing those evaluations and proposals. And we are currently giving feedback back to each of those 8 regions with the goal of getting those awards out to each of the regions by the first week of September.
I wanted to find more information on the Rural Health Transformation Grant. Is there a website we could go to?
Yes, there is. There is a website you can go to, and if you Google Indiana GROW RHTP, that would be the way to access it. I think the hyperlink it's GROW Indiana. I'll get back to you, but if you Google Indiana GROW RHTP, it will pop right up.
All right, thank you. So we're now going to review our financial results, and this is for the full year. State fiscal year 26, we'll be looking at enrollment and how the enrollment compared to forecast, expenditures, and then highlighting some of the watch areas that we are looking at. So the overview of the results, and again, we are comparing these results to our Medicaid forecast that was shared in December of last year. When we look at our enrollment, our ending average enrollment for the year came in 5.2% less than forecast, so less members than we were expecting. And we had less both for managed care and for our fee-for-service program. And then for our expenditures are coming in for the full year 4.1% less than forecast. So both of those are coming in below forecast. If we start with our enrollment and look at the managed care enrollment first, you'll see here highlighted. What? Pushed it too hard. All right. Little tricky today. Thank you. So for managed care enrollment, if you've been in any of these meetings, it's really the same story that we've been discussing, that enrollment is less than expected and that enrollment decrease, we're seeing more for the Healthy Indiana Plan and Hoosier Healthwise. And so both of those are really driving the overall decrease for the year. And I also wanted to mention, we were forecasting to see lower enrollment for both of those programs, but we just saw in the actual results even more decreases. And the reason I want to point that out, those are our two lower cost managed care programs. And when you think about overall financial results, we are losing membership in the less expensive programs throughout the year. If we look at the results in total for fee for service, again, it's a similar report to what we've been making in prior quarters. Our overall enrollment is lower for fee for service than expected, about 7% lower than forecast. And if you look at the last two lines on the enrollment list, emergency only and limited benefit populations, those are the two areas where we're seeing the most decrease in enrollment and the biggest variance from the forecast. And these are categories, these are emergency services only, is primarily for undocumented individuals. Their immigration status is undocumented, and they have very, very low costs as well. So we're seeing reductions in our lower cost areas and not as much in our higher cost areas. But overall, ended the year 5% below the forecast. If we look at our expenditures, overall, the bottom, you'll see that we came, for the year, we came in 834 million less than expected, which is about 4% less than forecast. In the gray bar, you can see the variances. Anything shown in black is a positive variance. So the only one that we have really showing a negative variance is our other expenditures and collections. And that is primarily related to our pharmacy rebates, and those have some timing issues as to when the numbers come in. So it's not like a long-term concern, it's just a timing issue for the year. If we look at each of those categories separately, all right, thanks. Managed care. So you can see at the top, the managed care came in 492 million better than forecast. We're showing positive variances to forecast for every program except for Hoosier Care Connect. Hoosier Care Connect is showing a negative variance because a decision was made to pay some risk corridor preliminary settlement payments out to our health plans in June that normally would have been paid in this fiscal year. And some of that had to do with delays in approvals and increasing the cap rates have, resulted in some cash flow concerns. So payments were made a little early. The only reason you see it for Hoosier Care Connect is that Hoosier Care Connect is coming in with membership aligned with forecast. So we did have some extra expenditures in the other program, but because they had a positive variance, you don't see them there. You only see them for Hoosier Care Connect. We look at our next category, fee for service. Overall, the results there were positive, but not quite as much of a margin there as for managed care. The areas that had some stronger positive variances were long-term institutional care and our waiver services. The area that had the biggest negative variance for the year is the last one on the list, our state plan fee for services. And there, it's some areas that we've talked about in other meetings where we're seeing expenditures higher than expected for a few areas, notably pharmacy, physician, and DME. So these are areas we will need to look at closely as we're preparing to do the forecast in December, but it is pretty consistent to what we've seen during the year. Next category is the other expenditures and collections, again highlighted at the beginning. This category is really dominated by the pharmacy rebates, and usually when we have a variance, it's because some came in sooner or some came in later, and so this isn't any difference. We just have a delay in some of those pharmacy rebates coming in, which is showing a negative variance for the year, but on an ongoing basis, it's not an area of concern. Finally, we have our manual expenditures, and in this category, we're showing a large positive variance, but unfortunately, that isn't really a good news story. The biggest driver of our variance is our nursing facility supplemental payments. We have not been able to make our scheduled payments for the last 3 quarters because we're pending approval from CMS on the program. This is something it's a very high priority for us to address. We have a call scheduled with CMS. We've submitted some new information, but that's why we're showing such a positive number there. We would prefer not to be seeing that variance. I would say the other area to highlight is we're seeing a negative variance for our DISH payments, supplemental payments to hospitals. And that's because some payments that were scheduled to be made later this year were made earlier than anticipated. So those timing issues are really the drivers there. And then the last couple of slides are some of our watch areas. Many times in these meetings, the watch areas are a graph showing where costs are going up high, or utilization is increasing, and that we're keeping an eye on it. This particular one on ABA therapy, you can see the results, and I would classify them as pretty stable lines where we're showing the number of recipients, both managed care and fee-for-service, and the expenditures, and those have leveled out. And I think in this case, we're going to continue to watch this. We've implemented some changes to the program. We would like to see those recipients staying flat, right? We'd like to not have any issues with access or drops, unexpected drops in participants. So we will continue to watch these, but right now we're seeing some pretty stable results.
Kathy, I just want to take a moment to thank the OMPP staff, and particularly Eric Miller for his work on the task force last year in creating this. Those numbers look refreshingly flat. Thank you.
Yeah, we hope to be showing some pretty flat numbers going forward as well. And the last watch area, so this is the one that is not such a flat one, but we mentioned it before. We're continuing to monitor closely the enrollment decreases that we are seeing under the Hoosier Healthwise and Healthy Indiana plan. And so if you were to look and say, well, how's the enrollment change? We're seeing decreases every month, but year over year. So from March of 25 to March of 26, the HIP enrollment dropped by about 155,000 members. So I have an audience participation question here. When was the last time our HIP enrollment dropped by that much in a 12-month period? Anybody know? So it's actually a trick question. It's never happened before, right? This is the biggest drop in the history of HIP, right? That we're seeing this much of a decline. And so that's why it's a big concern, both the HIP program and Hoosier Healthwise. We've never had that type of membership decline in that short of a period before. And it has implications for our rates and, making sure that our rates are appropriate. So this is an area where we're going to continue to report on this. This data is through the month of June. Earlier this week, we received our enrollment report for July, which is continuing to show additional decreases, another 3% decrease for HIP and about 1.5% for Hoosier Healthwise. So there's a lot of focus on this and making sure that we're rating appropriately for the risk that is remaining in these programs. You should expect that in future quarterly meetings, this is something that we'll be reporting on, and you should expect some discussion on this and the implications later today as well in our presentation. So with that, I'm going to turn it over to Leslie Melton.
Good afternoon. We wanted to share with you our final Medicaid assistance financial position for state fiscal year 2026. With our expenditures coming in at 19.7 billion and our intergovernmental transfers and federal funding coming in at 15.2 billion. That leaves us with a general fund need of 4.5 billion. Our actual state fiscal year 2026 general fund appropriation was 4.8 billion. So that leaves us with a surplus of 310.8 million as our final surplus number.
All right, this piece of the presentation is going to be focused on maternal and infant health. Before I begin, I do want to connect this presentation to last quarter. Last quarter, I also presented on some maternal and infant health metrics. Last quarter, we focused on delivery volumes, delivery expenditures, talked about some of our prenatal and postpartum quality metrics. This presentation today, I'm going to be much more focused on some of our clinical pieces. So we're going to be looking at things like maternal risk factors and infant clinical outcomes. We'll also talk about what we're seeing as far as expenditures in the infant category. This slide focuses on Hoosier Healthwise and looks at what we expect to spend on infants in the Hoosier Healthwise population. The reason that we focus on Hoosier Healthwise when we talk about infants is because 98% of our infants are in the Hoosier Healthwise program. So you can see here that the average PMPM for the infant category, and I know it's called newborn, but it actually covers from birth to the first birthday. So that infant age range is about $934. The PMPM is largely driven by that inpatient spend. So that's about $661 or about 71% of that.
Can you help me understand, what does PMPM stand for?
Yep, PMPM is per member per month.
So you multiply that 934 by 12 to get the annualized figure.
Correct. Yep. The inpatient costs are going to be largely driven by our higher acuity cases. So if we look here a little bit deeper into what's driving our costs, the slide is showing that inpatient hospital is our highest piece of the pie. And so we're talking about those NICU cases, higher acuity infant cases. So when we're looking at opportunities to improve not only our cost profiles, but also quality metrics, things that can reduce inpatient stays for our infants and reduce those NICU admissions are going to be areas of opportunity that we have. This is looking at our fee-for-service population specifically. So last quarter, you might remember we highlighted our average delivery costs. And during that presentation, we talked about that fee-for-service delivery costs were actually the lowest. So that prompted us to look a little bit deeper into our fee-for-service delivering mothers and ask, who are these moms and how did they end up in the fee-for-service eligibility category? So this is a breakout of the fee-for-service delivering moms, and you can see about 70% of our fee-for-service deliveries are associated with the package E and the package B. Those are just aid categories. So what that means essentially is that those members become enrolled in those limited benefit eligibility categories because of their immigration status. Next, we wanted to look at 3 significant maternal risk factors. So we're focused on hypertension, gestational diabetes, and preeclampsia. We isolated the cohort of moms from our most recent full calendar year, so calendar year 2025, and we found that across all 3 measures, managed care populations have higher rates of the maternal risk factors than fee-for-service. On the table at the right, we can also see within managed care, Hoosier Care Connect consistently has the highest rates of these maternal comorbidities. I don't think this is surprising given the complexity of that population. We also wanted to look at how does this trend over time? So we looked at our most recent 3 calendar years worth of data. So from calendar year 2023 to 2025. And I think at a high level, the takeaway here is generally stable, but we do have some trends. Hypertension specifically shows the most notable increase across all of our programs. So fee-for-service and managed care over that 3-year period. Gestational diabetes and preeclampsia, relatively stable. So this slide is shifting from our maternal comorbidities into our infant side, infant outcomes. So looking at the numbers here, you can see that Hoosier Care Connect, or HCC, has our highest rates across nearly every adverse infant outcome measure. HIP and Hoosier HealthWise are relatively similar. Fee-for-service in general demonstrates the most favorable outcomes, particularly for that neonatal drug exposure category. I did want to call out with neonatal drug exposure that it does include both prescribed and potentially illicit drugs that mom would have taken during pregnancy that would have had a physiological effect on the infant. I think overall, the infant data is generally consistent with what we're seeing in our maternal risk profiles for the programs. So this is looking at the trends over time. Again, looking back at the most recent 3 calendar years, I think the takeaway here, most of our infant outcomes have remained relatively stable across the programs. The notable exception, again, is our Hoosier Care Connect population. We see some increases across those adverse outcome measures. Most pronounced would be in that low birth weight measure at the bottom. At the top of the table, I do want to pull out as well, you're going to see the delivery volume trends. So you can see that delivery volumes were down in all of the managed care programs from 2025 compared to 2023. There was an increase in our fee-for-service deliveries. We also sliced it a little bit differently to look at those outcomes based on the MCO, or the managed care organization. So our 4 major MCOs, kind of going from left to right, show relatively similar performance across most of the measures. You will notice United Healthcare appears to have higher rates across several of the outcomes. I do just kind of want to caution, their only H program contract is with Hoosier Care Connect. So it was 29 deliveries in calendar year 2025. It's a very, very small sample size. This is again looking at the trends. So over the 3-year period, MCO infant outcomes have been relatively stable. Again, calling out United looks really off, but it's a very small sample size. So even small fluctuations are going to result in large percentage changes there. When we did our deep dive into the populations, we also wanted to see were there significant variations in maternal age. So for deliveries in, again, calendar year 2025, we see managed care has a higher proportion of the younger moms. Fee-for-service has a higher proportion of the older moms, so the 36 and older. Managed care, a slightly higher percentage of deliveries for moms that are 18 and younger than fee-for-service. This is a little bit different view here. I think if we put aside the 45 and up chart, which again has to be interpreted with caution, it's a very, very small sample size. We see in general, mothers at the youngest and oldest ends of the age spectrum generally have the higher rates of the adverse infant outcomes, and outcomes are generally more favorable in that middle range. I think this finding, again, is going to reinforce how do we target interventions for our highest risk maternal populations. And lastly, we wanted to look at infant outcomes by provider region. We see that managed care serves a larger proportion of rural deliveries than fee-for-service. We also see higher adverse infant outcome rates in our rural provider regions compared to our urban regions. Yeah.
So it's hard to know here because of the discrepancies in the fact that fee-for-service does so much better. Their health outcomes are so much better. You're going to naturally skew
I think I hear what you're saying. It's association, not necessarily causation, right?
yeah.
Yeah. So I think just closing, here are our key takeaways. I think first, again, reiterating the largest driver of cost for infants is the inpatient care for the higher acuity NICU types of stays. Second, we see managed care has higher maternal risk factors, generally less favorable infant outcomes than fee-for-service. Third, maternal risk factors, particularly looking at hypertension, it's trending upward and it could contribute to future increased costs in those infants. Fourth, our rural populations, there is an association there with higher rates of adverse infant outcomes. I think that's going to, again, highlight the importance of the work that we're doing with rural health transformation as well. And then finally, I think that the last takeaway is that, you know, we as Indiana Medicaid have traditionally focused our quality infrastructure in this space on process type of measures. So we really need to start looking at how are our quality initiatives translating into improved health of our population, and how are those impacting the clinical outcomes of our mothers and our infants.
All right, now I will review our Medicaid administration budget. So when you look at Medicaid spending, you're going to take the Medicaid assistance budget that Kathy reviewed and also the Medicaid administration budget. So collectively, that is the Medicaid spend. So I would like to highlight that the Medicaid administration budget is less than 1% of that total spend, because we are spending our money on care and services for the Medicaid member. Admin is typically funded federally at 50%. However, there are a few categories that receive a higher match. Those include the items listed here: claims and eligibility, EDI 90%, claims and eligibility M&O, as well as the EVV and our program integrity are at 75%. So we look at all of our Medicaid admin spend and we figure out what percent are we at for federal match. And that's kind of what we're measuring for. This year, I'm very happy to report that we were able to achieve 75% total federal funding for Medicaid admin. Total expenditures in Medicaid admin for state fiscal year 26 equal $167 million. 91% of that was in contracts and services. 7% of that was in salary and benefits, and 2% was in other admin, which is IoT and state allocations. The Medicaid administration summary: at year end, we're showing a $26 million surplus, with $17.2 million of that being general revenue fund. Well, we are good. We are not that good. And a large driver of that is a lag in invoices. So we will be paying that out here during Q1 of state fiscal year 27. Our Medicaid staffing, we closed out the fiscal year with 116 employees. Our average for the fiscal year was 110. Here are the major contracts of Medicaid admin. You can see that we are under for many of these contracts. Again, that's due to a lag in invoicing just with the fiscal year cutoff. And with that, I would like to thank you for being here today. We really do appreciate it. And thank you for your attention during our presentation.
Okay, thank you. We do not have any questions. Quick reminder, if you do have questions, you can email them to the Ask the Secretary at FSSA. Oh, we have a question over here. Okay. If you have it, just hold it up. Yeah. And if anyone else has questions, just hold them up so I can see it. Thanks. Okay, how much was recently reverted to the state's general fund from Medicaid, and why can those dollars not be used to move people off the Medicaid waiver waiting list?
Answer that, or should the secretary?
Is that really, is that?
First of all, we don't have those waivers slots available at this point in time. We would need to go to the federal government and get those waiver spots. And we may choose to do that, but we really want to take a look at what our longer term budget projections look like. So this 2026 was a tremendous year for us, but what you'll hear in my presentation this afternoon are the challenges that we face on a per member per month basis. So Kathy referenced in her conversation that we were concerned about the lack of reduction in the cost of care, right? Our cost of care simply has not gone down. And and in the out years, our revenue will be cut significantly because we'll go from 6% of the hospital assessment fee to 3.5% of the hospital assessment fee. So before we were to implement long-term permanent changes in the Medicaid program, we would need to understand what the Medicaid, what the fiscal, the longer-term fiscal picture is for the Indiana Medicaid program. So we'll be doing that at the December forecast meeting in front of the State Budget Committee. And then during the budget cycle, we'll have those discussions about what we want to spend dollars on. There are many people in this room who would like to spend that money, that $310 million. Those are hard ones, that's savings. And I will guarantee you that it would be spent 3 times over by the occupants in this room in places that they think are absolutely vital. And I don't denigrate for them for that. That's their job, is to work for the people they care about. And it's my job to make sure that we maintain a fiscally stable Medicaid program so all the people in this room and the people you represent can be comfortable that their programs will not be cut dramatically, which is what happens when you have a fiscal downturn. They come and whoever is running state government at the time ends up taking a hatchet to the Medicaid program, and we do not want a hatchet taken to the Medicaid program.
What is the state doing on the Medicaid admin side to ensure that people who are eligible for Medicaid remain eligible and to lessen the paperwork and delay errors?
That's really an issue for DFR. Medicaid, that's where the majority of that is focused. So, I mean, it is DFR's responsibility to make sure that the individual is is presenting information that allows us to keep them eligible. It is not our responsibility to make them to make them eligible. It is our responsibility to verify that they are eligible.
Okay, thank you. We will now take a break and return at 1:30 for the Division of Disability, Aging, and Rehabilitative Services. Okay, thank you, everyone. Thank you for coming to the Indiana Family and Social Services Administration's quarterly financial review. Next, we have the Division of Disability, Aging, and Rehabilitative Services. A quick reminder as they get set up, if you have a question, you can email that question to the Ask the Secretary at FSSA.in.gov email address, or you can fill out a note card that we have back here, and we will read those questions after the presentation. Thank you.
Good afternoon, everyone. I'm Kelly Mitchell. I'm the Director for the Division of Disability, Aging, and Rehabilitative Services. We're pleased to be here today to share with you our quarter 4 for state fiscal year 26. I also have with me on the stage our Deputy Director, Kathy Robinson, and our Chief Operating Officer, Jessica Harlan York. And you will be hearing from each of our Bureau Directors as we progress through today's presentation. Just a quick overview, the division is comprised of 4 bureaus: the Bureau of Child Development Services, the Bureau of Disability Services, the Bureau of Rehabilitation Services, and the Bureau of Better Aging. And with that, I'm going to turn it over to Kathy Robinson, who is going to lead us through the Bureau of Child Development Services.
Hi, everybody. Good afternoon. As Kelly said, I'm Kathy Robinson, the Deputy Director for DDARS. This presentation, portion of this presentation would normally be presented by Christina Commons. She's unavailable today. She's the Director for the Bureau of Child Development Services. However, I used to be the Director of the Bureau of Child Development Services a long time ago, and benefited from First Steps. My son benefited from the First Steps program a long time ago, back in the 1900s. But I'm here today to kind of talk through the First Steps early intervention information. I'm going to start with this slide. If you've attended our QFRs, this should be familiar to you. This is representing the total number of children served by county. And then the darker map of Indiana next to it represents the percentage of children served who are 250% or below the federal poverty level by county. And we do show that map so that you can see the data showing program resources are going to those families who are in greatest need. I'm going to talk just a moment about the First Steps supports for children and families. First Steps is more than just a clinical therapy session program. It is a comprehensive support system for individuals and families. So that really makes it quite different from outpatient clinics. Those are therapy services that are happening in the community where children are growing and thriving and have normal routines in their everyday life where families can get support in helping them reach their developmental milestones. This was particularly for families like mine, a benefit because we learned in the course of caring for our kids the best way to meet them where they are developmentally and pick up and learn the strategies that they need to meet their developmental milestones. This slide is yeah.
I know I'm a broken record on lots of stuff, this included, but it is wonderful to me that therapy is delivered in the home. And I wish we were able to do more ABA therapy in the home than in clinics that we have. I think the final point you made, which is learning by watching how a professional interacts with your child, is incredibly valuable. And life doesn't happen in a center. Life happens at home and at school. So I'm hopeful that over time we can move more and more of that therapy into home, school, and daycare settings.
I know I said that he received services in the 1900s. That is true. A lot has changed since then, but a lot hasn't changed since then. And that developmental teaching model is one that I think has stood the test of time. And to your point, Secretary Roob, has been maximally beneficial to individuals and families who are able to receive those services in their home and community settings, as opposed to a clinic-based setting where those they don't have as much access, and maybe the transferable aspect of that isn't realized to the same extent. On this slide, we're going to talk a little bit about the First Steps data. I'm going to focus on a couple of places here. One, for sake of time, because I know we have a lot of information to go through today, but just want to share the quarterly referral trends by state fiscal year, and that's in the top corner with the color graph, where you can see the trends and referrals over time has been relatively consistent. But you can see again, the majority of the referral sources are coming from the same places. The physicians, family, friends are the primary sources. And then I'm just going to spend a second talking about the exit data, which is down here in the corner next to Jessica. And really the number of children exiting with outcomes met, meaning those children, when they exited First Steps, essentially graduated and were meeting their developmental milestones compared to similarly aged peers. And I think that that number is important, the exit information reflecting that 24% of those kids were exiting with their outcomes met. This slide really highlights a lot of the effort that Christina and the First Steps team have engaged in over the past several years in the First Steps recoupment efforts. I won't go into a lot of detail as far as the numbers, but just to reflect here, the FSSA and BCDS braids and blends a variety of funding sources. And you can see over time what that looks like. Because First Steps operates on a pay and chase model, meaning we pay providers for the services rendered, and then First Steps goes on a recoupment effort to bring back funds as appropriate, depending on the funding source. You can see some fluctuations of insurance recoupments and Medicaid recoupment, family cost participation payments. Those all kind of work together to support and sustain the early intervention services that are provided by the First Step system. I want to note here really just how we ended the state fiscal year. First Steps had over 13 million remaining. These are also, again, in recognition, the variety of funding sources. So I believe most, if not all of that money was essentially used as shore up funds for the Medicaid match that is used to support a lot of the First Steps services. And with that,
different home and community-based services waivers, as well as providing intake and eligibility determinations for individuals with intellectual and developmental disabilities. Slide, please. I want to spend some time this morning this afternoon, talking about our level of care. So BEADS launched new assessment tools for assessing ICF-ID functional eligibility or level of care. That happened at the beginning of this calendar year. We began assessments in February 2026, utilizing these new tools.
The requirements for ICF ID level of care or functional eligibility have not changed. Simply the assessment tools we use to assess individuals. The ICF ID level of care assessment tools and assessments are conducted by BEAD staff. These would be the staff in our local district offices that I mentioned a moment ago, as well as our case managers that support individuals on the family support and community integration and habilitation waivers. These assessors, if you will, the state staff and the case managers were trained towards the end of calendar year 2025 is when that training began. We employed a train the trainer model where our vendor came that included some Inter-I fellows, the developers and the researchers that developed those Inter-I tools or assessment tools. They came, they provided training to trainers. Each case management organization of the 5, and I'll provide a little more information on that shortly, had 2 to 3 representatives at those trainings, and then are responsible for training their employees, their case managers that work in that case management organization. At the same time, around those trainings started in November, I believe. We also started office hours where train the trainers could contact us directly with specific questions around the training, the assessment tools. We initiated learning collaboratives for those mentors, those trainers around the Inter-I assessment tools. We do employ 3 different tools in determining ICF ID level of care. That depends on the person's age. The early years assessment is used for individuals 0 through 3 years of age. The CHIME, the Child and Youth Mental Health and ID assessment is for youth 4 through 17, and then the ID Intellectual Disability Inter-I tool is for 18 and up. So all the mentors, the trainers were trained on all 3 tools. And again, the learning collaboratives address all 3 assessment tools. In addition, we have recorded trainings available in our learning platform for case managers and our state staff as well. We have learning resources, fact sheets available in our IT, case management IT system, lovingly referred to as the portal right now. So those resources are available whenever a case manager, a state staff needs a refresher. And of course, we have dedicated staff here in central office in BEADS that focus on level of care assessments and determinations. Prior to this calendar year, kind of going back to the data here, prior to this calendar year, we had a homegrown tool that we use to assess level of care for individuals with intellectual and developmental disabilities. That tool was called the Level of Care Screening Instrument, or LOCSI. That tool, as you can see, as is indicated on the slide here, in state fiscal year, we had a level of care or functional eligibility approval rate of 99.8%. In state fiscal year 25, that same approval rate was 99.6%. So that's a clear indicator that we weren't appropriately assessing individuals' needs. So in 2024, we announced the plan to move to the Inter-I suite of instruments for assessing level of care. We began again assessing individuals with intellectual and developmental disability with the 3 tools in February. And the bottom half of the table indicates here the total number of determinations made and the approval rate, which as you can see is 94% overall approval rate with a 6% denial rate. So using these age-appropriate tools that are also standardized and validated, we have seen an increase in the number of people no longer meeting level of care or not meeting level of care when they when they apply for our services. We have approximately 1,700 assessments that are pending review as well. Again, those reviews are completed by state staff. So if when a case manager completes an assessment, if it's questionable whether that person meets that functional eligibility, that particular assessment is reviewed by state staff. The assessment's reviewed as well as a service record, the service record for that individual in order to validate that assessment. And that is all before a final determination is made. BEADS does make the final determination on level of care. I want to emphasize here that there is absolutely no AI involved in the assessment process, nor in the determination process. I'll say it again. There is no AI involved in the assessment process or in the determination process. When there is, any level of care decision on functional eligibility, a letter, that decision or determination is given to that individual in writing. That includes appeal rights. So if an individual is found to no longer meet or not meet that functional eligibility, they are notified in writing, and that document includes their right to appeal. If an individual chooses to appeal that denial, their services remain in place throughout that appeal process. There is a transition process that is initiated at the time of a denial, regardless of appeal status, and the case manager is responsible for facilitating that transition process and supporting the individual in identifying additional resources and supports in their community. Next slide, please. Nursing facility level of care, which is the functional eligibility for individuals seeking the health and wellness waiver, the pathways for aging waiver, and for some individuals on the traumatic brain injury waiver. Those level of care assessments and determinations are issued by our level of care assessment representative, or LCAR vendor, who is Maximus. Maximus conducts the nursing facility level of care assessments only. They do not conduct the assessments for ICF ID level of care. Again, that is trained state staff and trained case management that does the ICF ID level of care assessments. And you can see we remain around 10% denial rate, 90% approval rate for nursing facility level of care, which is consistent with the approval rate prior to the launch of the level of care assessment representative in 2025. These are our waiver metrics. These are the 4 BEADS administered waivers. Demonstrated here, you can see that BEADS supports 53,725 people through home and community-based service waivers. We have additionally, we have the number of individuals on waiting lists for those same waivers demonstrated below each of the graphs. The table that you see also includes the 4 administered waivers, and it includes each waiver's unique waiver year and the capacity within each of those waivers. And those are determined by submission and approval by our federal partners at CMS. The slots assigned are those individuals that are active on a waiver, and the open invitations and reserve capacity are those individuals that are in process of moving to active. I do want to highlight in the far right column is the number of invitations in state fiscal year 26. So as I mentioned, we're supporting in BEADS over 53,000 people in Medicaid waivers alone. We also invited over 6,700 to join those waivers in state fiscal year 26. So we continue to see growth in those waivers.
Do you know how many people accepted last year?
The open invitations, Secretary Roob, we have what we look at as kind of a throughput. So we invite individuals, most individuals will accept the waiver. However, Not everyone makes it to active status for various reasons. That may be that they have made other arrangements for their services, or they no longer have the same level of need of services. We see a higher percentage of individuals going active from open invitation on the family support waiver, which I believe runs in the 70% range. And then the health and wellness is a little under that, where not everyone that is open or that is invited makes it through to the actual waiver.
At one point, we were at 40%.
That was, I believe,
The
the pathways.
pathways waiver,
that's a
the free
pathways.
food is still around 40%. I do think the health and wellness is in the 60%
It's-
range,
yeah.
and family support waiver is around 75%.
Okay.
It's a little higher.
Thank you. Next slide, please. Oh, I think that means I'm out of time.
You're fine.
Okay,
You
thank you.
can have about another 7 minutes or so.
Okay, thank you. The demonstrated here is the percentage of population served across the top of that table within beads. The pie chart, I won't spend a lot of time on, but that is the expenditures, the Medicaid expenditures within beads, and the percentage of those expenditures by the various programs. I do want to just draw attention to the waiver spend per member per year, and then the Medicaid spend per member per year. You will see demonstrated per waiver, the average waiver spend, which is the third line down. So for example, on the family support waiver, that's $14,000 a year. But if you look at the total Medicaid spend, you're really talking about $32,000 a year, all in Medicaid expenditures on average per member per year. Next slide, please. This is similar data on our facility-based and institutional services, specifically our supervised group living or group home.
Holly, I'm sorry. Can you go back to the last slide?
Yes.
Okay, so I'll be talking about this in my presentation, the duals number on the bottom. So these are people who are dually eligible for Medicare and Medicaid. We need to do our very best to increase that duals number, because that duals number really decreases the what we call the state plan spend. It has a dramatic effect, which I'll highlight during my presentation this afternoon.
Thank you for highlighting that, Secretary. This is similar data on our facility-based, as I mentioned. So you'll see the per member per month or per member per year Medicaid spend for our supervised group living is about $118,000 a year. Our large private is about $187,000 a year, and that is our comprehensive rehabilitative management needs facility, or CRM&F, which is, we have one in Indiana. It's 21 bed, and it serves individual adults with intellectual disabilities who have the most extensive support needs and require a secure setting. So that's a small population. Next slide, please. So we continue our journey towards our waiver reset. Our waiver reset goals are listed here: implementing a sustainable service delivery system, simplifying the system, improving support coordination, and then enhancing quality outcomes. Our levers that we're using to ensure some quality and cost containment includes implementation of support tiers, support budget tiers, and then looking at our complete waiver design and the number of waivers at the time of waiver reset. Waiver reset is a large initiative and a very important one, at least from BEAD's perspective and FSSA's perspective. Phase one, we have broken it into a couple different phases. Phase one includes the case management structure change. So as of August 1st, BEADS now selectively contracts with 5 case management organizations. Many reasons for doing that. But the main reason is that we need to and want to enhance the quality of the case management service provided to individuals in home and community-based services. So we are also planning for some additional technical assistance for care coordination to support a more holistic view and holistic approach to supporting individuals on our waivers. Additionally, phase one of waiver reset includes a youth waiver. We intend, and I'll talk a little bit more about this, but we will establish a youth waiver as part of phase one, which is now through 2027, and then work to start transitioning youth to that waiver in 2027. Phase two of waiver reset, which is really 2028, we will be launching our support needs budget framework, which I just mentioned briefly, and we've talked about previously. And then we will also transition remaining individuals who are 22 years of age, stand up some new services or stand up some new waivers for the 21 plus population, and then look at our entire HCBS service array across all the BEADS administered waivers. So we're very excited about the opportunities that waiver reset offers us and the individuals we support. We do recognize as part of that waiver reset, the case management is key. Case management and care coordination is key to success for individuals and families and waiver reset. Again, another reason that we have gone with the selective contracting for case management. Fine. So the youth waiver is intended to launch July of 2027, which feels like tomorrow. And it will support at launch youth 0 to 21 or through 21 that have an intellectual or developmental disability that are served on the family support waiver today. So the initial launch will include that particular population onto the youth waiver with a modified service array focused more on the needs of youth. And then in 2028, that youth waiver, the other individuals on our other waivers that exist today, so the youth 0 through 21 on the health and wellness and the youth 0 through 21 on our other waivers, will then migrate or transition to the youth waiver at the time of the full waiver reset. At that time, we will amend or we will stand up new waivers and sunset the existing waivers today, maintaining that youth waiver. Right. And then here you see our Medicaid expenditures. Want to draw most of your attention to, you can see there's a little bit of red on there. We are spending more than last year, but we do remain within the forecast. And this is also the data that you see on the pie chart on the previous slide. And then lastly, our BEADS financial summary. You can see that we have had some variances in a few areas, but at the end of the fiscal year, we did all right. So I think that's it.
Yep. Thank you,
All
Holly.
right. Thank you so much.
Thanks, Holly. My name is Jessica Harlan York. I am the Chief Operating Officer at DDARS and have the pleasure of overseeing the Home and Community Support Professional Training and Registry. I'm going to share just a little bit of information quickly about this program as we have, it's been implemented for a year now, this last July. So excited about that. This initiative was the direct result of a larger vision to have a training program and registry of professionals providing direct support and services across home and community-based waiver settings and employment arrangements to ensure high quality, reliable supports and services, as well as to ensure administrative efficiency. Our efforts were informed by tons of stakeholder engagement with individuals with lived experience, providers, advocacy organizations, as well as direct workers themselves. Legislation pertaining to this initiative was passed in July of 2023, and this put DDRS on a fast track to develop and implement by January 1st, 2026. We actually were able to begin that prior to that, which was exciting. This is part of a bigger picture to build, monitor, and sustain a quality skilled and unskilled workforce here in Indiana. The total number of HCSPs, which is the acronym that we use, that have been certified from 7/1/2025 through 6/30/2026 is over 40,000, which is amazing and very exciting. Some of the training topics that are covered in this training are promoting health, wellness, and safety, person-centered practices, effective communication, community inclusion, and importance of documentation and reporting. And quickly, I just want to touch on some of the benefits that we were hoping would come out of this, that we are hearing from all the folks that are utilizing this platform, is that it's portable. It creates consistent training standards across provider organizations. It establishes better coordination of care. It improves the oversight of direct workers and providers. It can be a provider resource as well. The training can be used to provide resources throughout, the course of the person's employment. It establishes higher quality supports. It increases administrative efficiency for not only the state and providers, for not only the state, but for providers and the direct workforce. And it increases public transparency. And we were able to leverage a 75% match with this program. And just a couple more things. The recent developments, we launched the medication administration portion of the training, which it's part of the program, but it is separate. It's only for providers that are helping to administer medication. I can go ahead.
All right. Good afternoon, everyone. I'm Teresa Colazar, Director of the Bureau of Rehabilitation Services. We house 4 units in this particular bureau. The one folks are most familiar with is vocational rehabilitation, and I will speak mostly about vocational rehabilitation, or VR, today. The primary mission of VR is to support employment, to help people with all kinds of disabilities who are eligible for the program to achieve employment. However, I always want to mention our other programs because they're also pretty cool. We have a blind and visual impairment services, deaf and hard of hearing services, and then we are the state liaison agency for the Centers for Independent Living and the Independent Living Network in Indiana. Our largest source of funding across all of those different units is federal dollars, about 76% federally funded. However, we are required to put up a state match to access most of our different various federal grant dollars.
Just curious, have we maximized our state match?
I was wondering who was going to ask those questions when you stepped out, Secretary Roob. Currently, we are not fully leveraging all of our federal dollars. I hope one day that we can have a different response to that. We're working on that. Thank you. Next slide. Okay, this is the best part of my little presentation here. I really want to share a real impact, a real example of the impact of the VR program on Hoosier job seekers with disabilities. So today I'm really happy to share a little bit about Josh's experience. Josh had a bit of a long journey to employment. Sometimes, don't we all? Marked with several short-term jobs. He could find jobs, but really had a hard time finding the right fit and making that job lasting for him. He had a lot of different barriers to finding the right job setting, and again, retaining the jobs that he obtained, but he didn't give up. So while he was in the VR program, he received a number of supports. You can see them here on the slide. I won't go through them all, but I do want to point out career exploration, which was particularly important for Josh because we wanted to set him up for a successful employment experience, given some of the challenges that he had experienced in the past. Let's see, we also helped him with his job search. And I want to do a quick shout out here to Crossroads Rehabilitation Center. Crossroads is one of about 90 different employment service providers that we work with. So Crossroads worked with the VR counselor and Josh to help him find his outcome, which is also really cool. Josh secured employment just down the road with the Indiana Pacers and Fever team store, if you've all been there. There's a lot of hustle and bustle going on over there. We have a lot of individuals that we could share experiences about, but what I really, my big takeaway from learning about Josh is really a lesson in perseverance. So to kind of piggyback on the basketball theme here, my 11-year-old would be thrilled with that. our shot is not always going to go the first time, right? It's not always going to fall the second time, maybe not the third time. But if we keep rebounding, we create another shot, right? We create another opportunity. So Josh kept rebounding. And this is important because a lot of us in this network hear from individuals or their families or their support teams that somebody, well, I tried that. I tried working. It didn't work out. One bad experience does not necessarily mean an indication of future experiences. So again, I encourage people, right? Keep rebounding, try again. All right, moving on to a little bit of data here. Similar to what we've seen most of this year, the majority of VR participants are those with the most significant disabilities, about 80% of the population, while 18% meet criteria as eligible individuals with significant disabilities. The bottom pie chart on your left breaks down by very broad disability category, the primary impairment type. Again, that breakdown across the population. The largest two populations are those with a primary impairment of an intellectual or developmental disability at 37%, as well as those with mental health condition at 29%. A significant portion of folks, about a fifth, experience primary impairment of physical or mobility impairment, and then about 15% sensory, which is split fairly evenly across primary low vision and primary deaf or hard of hearing. We've been,
Teresa, can you
yes.
expound for just a little bit on how you're working, and perhaps you aren't, with the Division of Mental Health and Addiction, as well as the CCBHCs and community mental health centers?
Sure, yeah, I would love that opportunity. We have, I mentioned we have about 90 employment service providers. A small number of those are community mental health centers. Pretty soon, we will have more providers. So the CCBHC entities are making their way back into for the first time serving as a VR employment service provider. So we're really excited because the mental health population is a population that we feel that we could do more to be effective in helping them find employment. And we don't always have the right partners to do that. So we're really excited to start working with more community mental health centers, CCBHCs, to better serve this population. All right, a little bit more data here. If you've been attending these meetings, you've heard me talk a fair bit about a big focus this past year is getting to a more sustainable service level in terms of our available dollars and the growing population that we're seeing coming in the door. We did a lot of the hard work in state fiscal year 26 to really realize some cost savings. We're entering 27 in much better fiscal shape, a little bit of breathing room, if you will. We feel that we've closed our projected deficit for this biennium, which we've got a year left. We're halfway through the biennium. We shall see where we go from there. We're sustainable if our population kind of stays the same. But of course, we'd love to help more people. We'd love to see more people come in the door. All right, and then next slide. I just want to highlight a couple pieces on this slide. What I'm most excited to share is that for the state fiscal year that just closed in June, we had 2,874 individuals who exited with employment. Several other people remain in the system who also achieved employment during the state fiscal year, but we're still supporting them to learn those jobs, successfully retain those jobs, and then case stays open in VR for another 90 days after they successfully stabilize. So more individuals started employment, but 2,874 made it all the way through to stabilization, retention, and exited the system with employment. That's a 37% increase in the number of folks who exited with employment over the prior year, which is great. I also want to highlight the annualized earnings for those exits. So we capture data for at least 1 year after exit on employment retention and median quarterly wages. So when we calculate those quarterly wages for 4 quarters, for the number of individuals retaining employment 4 quarters after exit, that is an aggregate annualized earnings of $24.6 million for state fiscal year 25, which is an increase over the prior year. Now, I don't have state fiscal year 26 data just yet, but we are anticipating that we'll continue to see that trend going up, and I will have that for the next quarterly once all of our state fiscal year data closes out. I'll also quickly highlight, we saw some notable increases in the number of individuals who receive one or more services and then exit with employment. The percent who exit the system, the percent who exit with employment did increase. About half of the folks leaving after service are leaving with employment. And then finally, just a couple notes on the next slide, some fiscal data. Our budget intent all year was to have some positive variance. That gets us through this next half of the biennium. We still got a year to go. And again, we've been able to do that through cost containment efforts, as well as some shifting of some match dollars within the broader division. And as I mentioned, we do believe we've been able to close that projected budget gap for the biennium. We did a lot of that hard work this year, as I mentioned, so we feel a little more stable going into state fiscal year 27. There is a discrepancy I want to point out here in our state variance. There is no state variance. We've learned a lot from budgeting in a different way this year and these quarterly, and we also do monthly financial reviews. And so you'll see some corrections in our available state dollars for the next year. There is no variance in state dollars. The budget here is just not quite accurate. There is some variance in federal dollars. Again, that's intentional. That will all carry forward as intended to help with services through the remainder of the biennium. Thank you very much.
Thank you, Teresa.
Good afternoon. My name is Erin Wright, and I serve as the Director of the Bureau of Better Aging. The BBA serves Hoosiers by facilitating access and support so individuals may age in a dignified manner of their choosing. We serve as Indiana's State Unit on Aging, and with that role, we designate a network of area agencies on aging to serve older adults and caregivers throughout 16 regions in the state. The AAAs accounted for about 68% of the BBA spend in state fiscal year 26. Indiana Code was updated last year to include language about conducting a study to look at the distribution of the AAA service regions, or the map that you see here. So we are working on information gathering and data analysis related to potential map designs. BBA supports a wide variety of non-Medicaid home and community-based services. Today, we would like to introduce you to Betty, an individual, a BBA staff member met at one of our local AAAs. Betty is an 87-year-old widow living alone who has heart problems. She struggles to afford healthy groceries and cook for herself. Her friend suggested she contact a local AAA to learn about programs that can help her stay healthy, supported, and independent at home. Through the local AAA, Betty was able to connect with transportation to a nearby congregate site, as well as home-delivered meals. 1 year later, Betty reported improved nutrition, which contributed to better heart health, increased independence, and a reduction in her heart-related medical appointments from every month to only once a year. So with this example, we see Betty access several services resulting in positive outcomes. She was connected to community resources and support, such as information and assistance and transportation. There was a reduction in social isolation, reducing the likelihood of poor health outcomes associated with social isolation-related health risks. And there was improved nutrition, mitigating the risk of malnutrition-related medical costs. Last year, Indiana's Aging Network provided over 1.5 million meals to over 15,000 Hoosiers. So this is an example of a single AAA contact activating a chain of coordinating supports that not only meet an individual's immediate need, but can have broader system-wide impacts. On the slide, we've highlighted our state-funded choice program. We are continuing to see a trend within the choice program where attendant care, home and community assistance, and case management are the top 3 services. We expect to see a shift in state fiscal year 27 as we increase focus on prevention and earlier intervention within this program.
On the meal piece here, I'm sorry to interrupt. I'm surprised that a home delivered meal is 70 cents cheaper than a congregate meal. Does that include transportation? You don't have transportation
It
costs. do you?
includes the overhead for the space and the staff, and we tend to see when we're calculating the costs, higher in-kind contributions reported, which may have contributed to that as well.
Okay, it's just, I mean, DoorDash is not cheap, right? So I have never DoorDash, by the way.
I can work on a breakdown for.
It's just,
future
it doesn't intuitively, you go, that doesn't really, seems like a congregate meal setting would be less expensive on a per meal basis, but there may be vagaries that aren't, I don't know, it's just surprising.
So some of the home delivered meals are delivered once a week as a frozen, say, 14 pack or 5 pack. So there's not a daily delivery. Some of our sites do deliver a daily hot meal. Some are the frozen. Because of federal funding formulas and grant processes, we are generally not efficiently able to move funds between services and areas, and this has contributed to some waiting lists and some underutilization of resources. So you will see here with choice, we are projecting, or we have some funding remaining at year end. Some of this will be claimed in state fiscal year 27. Choice is the funding of last resort, so other options and programs are used first. We recently reorganized our bureau and now have a full-time choice program manager to help ensure we are maximizing the use of these dollars to serve Hoosiers. Next. For Title III of the Federal Older Americans Act, we are also showing some funds remaining at year end. We received around $42 million in federal funds, and there is $7 million unspent. A portion of this was Older Americans Act COVID dollars that expired last September, and the rest will carry forward. Turn it back to you.
Thanks. I'm going to do Holly a favor here and jump in so you don't have to run up on stage for 2 slides. This is our Money Follows the Person program. These slides will in future QFRs be in Holly's Bureau of Disability Services slide deck. So this just highlights our summary of participation with Money Follows the Person. You can see our utilization currently around or over 50%. And I'll have you go to the next slide to talk on this breakdown, which really is kind of illustrative to show the benefits of the Money Follows the Person program. It is a demonstration that allows states to access an enhanced federal match, again, supporting efforts to rebalance long-term services and support. So the benefit to the Money Follows the Person, obviously we have an opportunity to build out our HCBS supports for folks transitioning out of institutions, but this offers a greater federal share for us for 365 days for someone's participation in Money Follows the Person as a stability measure to hopefully keep them sustained successfully in their community.
Okay, that you didn't cover anything with pathways. Is Money Follows the Person's not, are we not doing that in pathways as well?
Yep. So this is everyone. So
PW is pathways. Okay.
Yeah,
Yes.
PW is pathway.
Beta Kappa, okay.
Specified. There's a lot of letters up there. So
We love
pathways-
acronyms.
Pathways is also included as a part of Money Follows the Person. Thank you for clarifying.
And you can see here, we still have some dollars left. We'll continue to be, I think we're still awaiting approval on the next year's MFP budget. But we still have some dollars remaining to support some of the services and supports offered there.
All right, Erin, back to you.
All right, thank you. So RCAP, the Residential Care Assistance Program, is a state-funded program designed to support vulnerable, low-income individuals who reside in licensed residential care facilities or county homes. Provides room and board and some medication assistance. In state fiscal year 26, the majority of the clients were male and about half were over the age of 60. 95% of the residents had some form of mental health disorder. Currently, there are 209 RCAP residents and 19 providers. Participation continued a downward trend till about midway through the year, and then since then it has remained relatively stable. This coincides with a mid-year rate increase. The top reason for discharge from the program last year was approval for one of the Medicaid waivers. So this program really fills an important gap, and we will be looking at opportunities in state fiscal year 27 to improve coordination and access to services for this population. I also will briefly highlight the long-term care ombudsman program. Next slide.
You didn't want to speak to the fiscal?
Oh, the other way. There was a little.
Oh, down at the
hair in
bottom,
corner.
sorry.
In the lower corner. So the Long-Term Care Ombudsman Program advocates for residents' rights in nursing facilities and licensed assisted living facilities. From October through June, Ombudsman visited 97% of Indiana's 737 long-term care facilities for a routine access visit, helping to build trust, observe care conditions, and educate residents. Now, thank you. With the RCAP budget, we ended the year with some funds remaining, so under budget. Today, I want to share an example of Adult Protective Services and our Adult Guardianship Program working hand in hand to protect a Hoosier and demonstrate how a single call to APS can launch a coordinated chain of protection. So in this situation, a concerned citizen reported a 24-year-old woman locked alone in a car during extreme heat. Law enforcement responded immediately and an APS report was filed. APS opened a full investigation, uncovering circumstances warranting the involvement of guardianship services. Through this collaboration, the woman received safe housing and long-term support that restored stability. Statewide last year, APS received nearly 10,000 reports and closed 9,100 cases, with an average resolution time of 26.6 days. In this particular case, it moved from first call to safe placement within just 6 days. So this case highlights positive outcomes stemming from coordination. While APS is not an emergency or rapid response service, law enforcement, APS, AGS, and the medical community move together, preventing further harm and avoiding costlier intervention later. The APS program is also showing funds remaining at year end. Some of this year end variance stems from unspent funds from the previous contractors, the prosecutor's offices, and some of it will be carried forward.
And have seen, we were hopeful in this program that we'd be able to find that the current vendor would be able to pull down additional federal dollars. Has that occurred?
So we have seen an increase in the Medicaid dollars that are going towards the program that'll be reflected in our 27 budget. And then we also will be looking for opportunities to leverage additional federal dollars through Medicaid administrative claiming. Our overall budget was around 151 million last year. Around 2/3 of that was federal funds, again, to support access and the provision of home and community-based services and supports. Most of the remaining funds, especially the federal ones, will be carried into 27. Thank you.
Thank you, Erin, and thank you to all of our Bureau directors. I'm going to wrap this up. You will see that the Bureau of Better Aging formerly was a standalone division of aging, and so you're going to see two administrative summaries. We ended the fiscal year in a strong position as we look at our administrative costs, our operating costs. As you can see here, we came in under budget on the aging side of things to the tune of about 38 million, state and federal funds combined. And then when we look at the traditional Division of Disability and Rehabilitative Services, which would have formerly been the Bureau of Child Development Services, Bureau of Disability Services, and the Bureau of Rehabilitation Services, as well as the administration executive team for the division, those expenditures came in a little over $31 million under the budget that was put in place. So we had a very strong year. I'm very proud of our achievements.
Can you go back one slide?
Yes. Good. So I will not read this slide to you, and I hope you will refer to it, but we are very proud of our achievements. The team, the leadership was strong. Aging, we were able to restructure and recreate or create an entirely new division as effective July 1 of this year. Movement toward waiver reset. Teresa, you spoke so eloquently of continuing to serve a growing population while bringing in cost with some reductions in funding. The same with the Bureau of Child Development Services. I think continuing to serve a large number of children and families and using some creative funding strategies. So with that, we thank you. You will see in our slide deck, we have some appendices, predominantly note our DDARS contracts. We have worked diligently with our vendors to bring those contracts in and kind of rein in some of those costs where possible. And the others are just some of the financial summaries for some of the smaller services and programs that have been closed. Nope. I was supposed to go to a QFR. It wasn't their little code.
Questions? Anybody have questions?
If you have a question written on a note card, if you could just hold that up if you're sitting in the audience. And we have a question from William Coulter-Yan. Considering the recent questions around the inter-RAI assessment, in particular, the jump in statistical jump in, I think what he meant to say is, in particular, the statistical jump in denial rates, are there plans to reevaluate the rollout?
Well, I believe that Holly Wensett addressed the majority of this question in her presentation. At the current time, we do not have plans to reassess the rollout. We anticipated an increase, if you will, in the rate of denial or the decrease in the rate of those found eligible. We have been communicating for approximately 2 years that we would have anticipated about a 10% denial rate. As Holly indicated, we are currently seeing a 5 to 6% denial rate with that level of care assessment tool. I will say, as Holly stressed, as always, an appeal process remains. If an individual feels there has been an inaccuracy in the assessment, they most certainly have the right to appeal. That will be reviewed. And while that is being reviewed and under appeal, waiver services continue. They are not disrupted, and no one is removed from waiver services during that appeal process. I will also say that when the Enter-I tool is implemented in the interview or assessment process, that is not the only piece. As Holly indicated, when that interview, that assessment indicates the possibility of denial or that the functional eligibility does not exist, that then goes to review by state personnel to validate that assessment. So not only is the interview and assessment process reviewed, but the case record is reviewed as well.
So you're saying that AI is not making decisions?
I am saying that AI is not making any decisions, yes.
Okay, we have another question from William Coulter-Yan. Regarding the NRI assessment tool currently in use, how was the tool selected? And was there input from professionals, caregivers, families? Was there a competitive bidding process?
Holly, do you want to speak to that? I can speak to it, but you have more granularity.
No, thanks for the question. So the Enter-I tools have actually been used in Indiana for a number of years, going back to about 2016. We've used the Enter-I for nursing facility level of care. So when we identified a need to obtain a new assessment tools for ICFID level of care, we naturally looked to that assessment tool because we had used it for years and we're familiar with that. We, in 2024 is when we started talking to stakeholders about utilizing the Enter-I suite of instruments for level of care assessments within our BEADS administered waivers.
Thank you.
Okay, we have another question from William Coulter-Yan. Regarding the appeals process, how much time from when the appeal letter is mailed out to appeal deadline? Are there people receiving letters after their appeal deadline?
Holly's jumping up. I'm going to let her answer.
Individuals have 33 days after receipt of the letter to file an appeal.
So that's whenever they receive the letter?
Yes.
I have another question from Amber Smersheim. Is the ICF ID assessment required annually? If so, can you explain why?
Yes, our waivers have always required an annual level of care assessment. That's any of the waivers BEADS administers, any of the waivers that were previously administered by the Division of Aging. What we have learned as we rolled out the Enter-I tools for the ICFID level of care is that case managers were not appropriately completing annual reassessments. We heard from families that said, why are you doing this now? And we said, well, we've always done this. It's always been a requirement. So we, again, we learned that some case managers were not actually doing in-person assessments prior to the implementation of the Enter-I tools, which is why we have invested a good deal of time and effort with case managers and case management organizations to be very clear that these Enter-I assessments can only be done in person, and the assessment needs to be fully completed at that in-person meeting. And if we learn that that is not happening, we will be addressing that with our case managers with which we have contracts effective August 1st.
She had a follow-up question. Do you intend to consider parental income when determining eligibility for minors on a waiver?
Okay, I'll let Secretary Roob take that one.
So we are beginning to collect information regarding that. Without any information, it's difficult to understand what the financial condition of the parents who have children on waivers. So we may decide that that's something to do. We may decide that it's not something to do. We are simply collecting the information. I would, for those who have raised concern about that, I would take you back to the closing days of the last legislative session, when a very bad and what turned out to be incorrect forecast was made. And that forecast said that we needed to implement a number of changes, not just in Medicaid, but in many other programs, public health, the Department of Corrections. We increased cigarette tax, and we didn't. And one of the things that's on the table every time that comes around is ending parental disregard for the waivers. It's important that policymakers have information when they're making choices, because it is possible that somebody says, well, we're going to do that this time without any information. So I think that having that information in hand will be important in future public policy making opportunities.
Okay, I have another question from Jennifer DeWitt. Could you share any additional details concerning the cross-disability portion of the youth waiver in 2028, specifically for those youth that are currently on the health and wellness waiver with extensive medical complexities / skilled needs?
I think I can answer that, but Holly, if you want to jump up, you feel free to. It will be all of the waivers once we achieve reset, not just the youth waivers, will be cross-disability. There will continue to be 2 unique assessment tools or assessment processes. So there will be individuals who are found eligible due to nursing facility level of care or NFLOC, which is the current eligibility criteria for health and wellness. And there will be individuals who are found eligible with an IID tool, or those that have an intellectual or developmental disability. The waiver, the youth waiver, will serve both populations, and the array of services will take into consideration that fact. But it really is meant to bring more consistency across the whole. We have heard for years from stakeholders that many times individuals and their families have had to make choices. Do I choose an IID waiver, or do I choose an NFLOC waiver? I can get my medical needs met on the NFLOC waiver, but I can't get perhaps some of these behavioral health issues or developmental issues met. So this is an opportunity for us to address that. Did I serve you well, Holly?
I have a question from Jim Wiltz. Is the denial rate on LOC assessments different for initial determination and redeterminations?
We are gathering that information. I don't think we yet have the entire breakdown. I will say I'm glad that we received that question. I don't know if that came forth as you were discussing the level of care assessments, particularly for IID. When you see that number of denials, that is not just redeterminations. That is not just individuals who are actively receiving waiver services. Those are also individuals who have applied initially and may have been found or may not have been found eligible.
And I have a question from Rachel Deaton. Did Indiana customize the inter-RAI assessment tool? Would this affect the outcomes of the assessments compared to other states utilizing this tool?
Well, I'm going to let you speak to that. I saw you on the edge of your seat, Holly.
States are allowed to add supplemental questions to Inter-I. That doesn't mean that they are part of, that those questions determine level of care, for example. So in Indiana, as in many other states, the Inter-I is used for eligibility, but also for service planning and identification, at the heart of it, identification of the individual's needs. So we did add some additional questions to help us with future state with the Inter-I in terms of service planning needs. And as we launch a support level and support budget framework, there was a need to add some additional questions to try and hone in on some very specific behavioral needs and medical needs. But again, all those additions to the Inter-I do not change the base Inter-I. We can't take questions away. No states can. We can only add to when there's a specific need in a state. And again, because we're going to use the Inter-I in service planning and in the support level framework, we did add some additional questions. There is a limit on how many items can be added to the Inter-I, and any addition has to be vetted through the Inter-I fellows and approved.
And have a question on a note card. Once a person is determined no longer eligible for services, and after they submitted their appeal request, what happens? When will their hearing occur, and how many hearings have occurred? And are decisions ever overturned?
So the hearings are scheduled through our Office of Administrative Law Proceedings. And I don't have data with me today on exactly how many appeal hearings are on the docket and what those outcomes are for those that have outcomes. But we do have worked collaboratively with that Office of Administrative Law Proceedings to be sure that we're coordinating on those appeal hearings and dates and testimonies and so forth.
And a question from Cassandra Velasco regarding the assessment. Can you talk a little bit about the Inter-RAI assessment, like how it's created?
From a very high level overview, the Inter-I Fellows are a group of researchers that develop those Inter-I tools. They have more than the 3 that we use for ICFID level of care. We also use the early years, the pediatric home care tool and the home care tool for nursing facility level of care. There are additional tools or instruments within the suite of Inter-I that are not used in Indiana, but they are all developed based on research and validation through the Inter-I Fellows.
Another written question from Lindsay Wright from the Indiana Association for Music Therapy. Can you speak on the moratorium for adding new provider services and counties for HCBS services?
I will speak to the moratorium. I'm not sure I understood and counties.
It could be me misreading it. I think it's counties.
That's the addition, the moratorium.
Oh, adding county, okay. So issuing the moratorium is really part of FSSA's efforts to eliminate fraud, waste, and abuse. In order for us to assess the quality of our monitoring, our enrollment processes, provider base, in order to recertify and revalidate providers, we felt it was necessary to place a temporary pause on enrollment. This does not mean that any current providers are being removed from the system. It is a pause on new enrollments. This will allow us to stabilize during that time frame. And our partners in OMPP are working on revalidating providers with their Medicaid enrollment. So there are some new requirements around that, particularly for our Medicaid waiver providers. A little bit more staunch, if you will, requirements in vetting ownership and controlling interest in those organizations.
Okay, thank you. That's it for questions right now. If you have a question, you can still email the Ask the Secretary at fssa.in.gov. email address. And we are going to now take a 15-minute break and return at 3 p.m. for the Secretary's closing presentation.
Thank you for being here. For those of you who don't know, my name is Mitch Roob, and I'm the Secretary of Socialism. And we are back in black. After a long 18 months, we are now back in black. So thank you. Thanks to the team behind me. Thanks to your patience. We're very appreciative of that position. Let's see if I can get this to work. Can you all hear me? Yeah, there you go. So Mark, do I have to move my own, bleed my own blood here? Okay, so we are returning. As you saw earlier, we returned last year $310 million to the Indiana General Fund. So we're tremendously proud of that. And it didn't happen by accident, right? It was a lot of tough work. So let's highlight some of the ways we did that. Stronger fiscal oversight, including regular financial reviews and ABA reforms. I will say, I have said this before, and I will say it at every QFR and every time that we do an MFR. For better or worse, I will not be secretary for life. This is not a death sentence. When I am gone, if whoever is the secretary is not running monthly and quarterly financial reviews, run to the governor's office, run to the legislature, and make them do it. I cannot tell you how much money we have found laying on the floor doing these MFRs and QFRs. In addition to that, it also provides the knowledge base for the providers about what else is going on in the agency and the other pressures that we face. So I think it provides a level of transparency which frankly is unprecedented in the nation. We are, by the way, the only state that does this, which actually I cannot believe we're the only state that does. It's terrible. We have must return mailers, many of you know, but ban on Medicaid advertising. What many of you don't know is that we have so far moved 320 eligible members to dual status. And over the course of this year, and that is thanks to Lindsay Lux, who's getting up and leaving, because so thanks to her and her team. And I mentioned this earlier. We save on the Pathways patient or member, on a Pathways member, we save $9,000 a year in state general revenue fund per person. So we're going to move this year, this fiscal year, we'll move another 10 to 12,000 people onto Medicare, and that provides us with a permanent savings, right? And of course, and we have not changed eligibility criteria. We have made during this process, we have not changed the eligibility criteria, and it is not our intent to change the eligibility criteria. But we have not cured Medicaid. Medicaid is not cured. So if you have diabetes, you can treat diabetes. You can work with diabetes. You can take insulin. You can modify your diet. You can lose weight, and you can live a relatively healthy and prosperous long life with diabetes. But if you don't manage it, right, you end up, unfortunately, frequently with an amputation. Similarly, Crohn's disease. You can live with Crohn's disease, right? Diets must be changed. But you can live with Crohn's disease. But if you don't, right, you end up with and unfortunately, all too frequently, a colostomy bag. You can live with celiac disease. My wife and daughter do live with celiac disease. But you've got to manage it, or the effects in the near term and long term are very bad. Medicaid is a fiscal chronic disease, and we have to consistently manage it and stay on top of what we are doing. There is no one-time cure for Medicaid, right? There is no one-time cure. It requires constant fiscal discipline. So we are no longer drowning in debt. You guys wondered where this is when I fell off that FSSA. So we are no longer drowning in debt. Our head is above water, but can we keep it there? So let's talk about what FSSA and Medicaid is. If this works. Yeah. So this is FSSA going through the budget buffet. Because we are an entitlement agency, right? We take what we need and we leave the rest for others. And those others are K through 12 education, higher ed, Department of Conservation, so forth and so on, right? That's me going through, right? And we need to be better. We need to leave more behind, right? For the other parts, for the other folks that are coming along, right? For K through 12, et cetera, right? We cannot be that piggy. Okay, I think they get the joke. Okay. So we have seen a significant decrease in enrollment, which we talked about earlier today, right? From the time Mike Braun took office till today, we're down about 22%. But we've only seen an expenditure decrease of 2%. The reason for that is our PMPM is skyrocketing per member per month. Let me give you some examples. But first on enrollment. So people have talked a lot this week. The Capitol Chronicle has decided to do stories on Medicaid's enrollment. This is from us, and I would reference this to you. And in the words of Rex Early, who remembers Rex Early? Oh, good. Rex Early used to say, "It's a mighty thin pancake that doesn't have two sides." Well, here's a piece from Paragon Institute that I would reference to you that we'll be happy to distribute to you. It's Medicaid expansion's growing improper enrollment crisis. The number of people that were enrolled in Medicaid incorrectly is pretty high nationally. You can see California there, very high. That's Louisiana, and who's next? Little old Indiana, right? So a lot of the people who have left the program and were probably never eligible and may never have needed services. So I'm going to walk through a couple of examples of what's happening to our PMPM and why I'm so concerned about the out years here. And that we are not, you notice we're wearing black hats, but there's no champagne, right? We're not ready to celebrate. So Healthy Indiana Plan membership capitation spend, okay? So here's the number of members, right? Goes up, and the per member per month rate goes down, right? And same on the other side. Capitation rate, membership goes down, capitation rate goes up, right? So what we're seeing is that the sicker, the patients who need care are seeking continued eligibility, and those who do not, frankly, are not. Because if you're a 25-year-old male, you're not having a health problem, are you really going to go fill out the paperwork if you haven't seen a doctor in 3 years? Here's another way of looking at it, and this is from Deloitte, who's our actuarial consultant. You'll notice here that this is again on HIP, enrollment versus acuity. You'll notice that enrollment is declining. We all know that, It's interesting to look, I'll talk more about this in the next slide, about the stayer count, the new entrant count, and the leaver count, right? Who's leaving, who's staying, and who's new. So you can see this breakout. The interesting piece here is that the new entrant count is about the same every month. So we're not dissuading people from joining for the first time. They are, which is fine. That's what it's perfectly fine with us. We want them to. But we've seen this increase in PM costs, per member per month costs. So this next slide, I think is even more revealing. So the lever, the person who, those levers who are people started talking about levers, like, why are we leaving? But no, the people who leave. Took me a while. They're costing $512 a month. The new entrants are $710. The people who are staying are $884. So what we've seen is a tremendous increase, and there are a number of people in the room today who work for health plans. We've seen we will end up having to do a mid-year Healthy Indiana plan rate boost because of this differential, right? It is that we're going to have to boost their rates 10, 12, 14% to bring them into line with what the claims cost that they're seeing. So you've seen this slide, kind of this similar slide before, and what it tries to point out is that HIP and Hoosier Healthwise and Hoosier Care Connect, they're relatively inexpensive programs, but the money is in the waivers, the fee-for-service, and pathways. That's where we're spending all that money. Look at the growth in the per member per month, right? We've gone from $1,000 10 years ago to over $2,000 this year. That's an enormous growth, right? And I'm not saying that it's not deserved. I'm just saying that we've got to do a better job of managing that patient population, both inside of Pathways, which is a capitated plan, and inside of the waivers. So we had a lot of conversation in the last. And I promised you that I know you wanted me really to do this. I promised you I'd come back to this duals piece. So the way we think about this, or the way Kathy thinks about it, and that's how I think about it, is that there's plan spend and there's waiver spend. So this doesn't deal with the waiver spend. Right, this leaves the waiver spend out. This is plan spend. So think pharmacy, clinical trips to a doctor, or something along those lines. So here's for the CIH waiver, right? The CIH waiver, 73% are on duals, which is great. That's as they should be, right? But look at the differential for those who are non-duals. The state plan spend is $670 for a dual. And for a non-dual, it's $2,500. You'll notice that the waiver PMPM is roughly equivalent, right? But that status is so important. Similar, and TBI is not as great a differential, but still there. Here's the one though that really I think will catch your eye. And that is health and wellness spend on duals versus non-duals, right? The state spend on the PMPM on duals is $1,100. On non-duals, it's $5,700. So we are spending an incremental $415 million on non-dual state plan spend inside of that waiver. And it's a little smaller, but just as marked in the FSW waiver. It's $384 to $1,509, right? So in total, on these 4 waivers, we are spending $835 million in state plan services that are utterly unmanaged. No one is managing that at all. Now, that's not true of the waiver side, right? We have case managers that manage the waiver side. They are not the case managers have historically not been responsible for the plan spend. So we are going to we are in the process of hiring a vendor to help us manage this medical spend to work alongside of our new case managers. And we are hopeful that we can lower this plan spend. In addition to that, we need, as I referenced earlier, it's critical to us that we increase the dual population, right? Because that dual population, that saves you saw how much money it saved, right? Every time, and that's a month, right? That's not a year, that's a month. The PMPM, we need to figure out ways to manage the PMPM for non-duals. So unfortunately, waste, fraud, and abuse are a truism in Medicaid, right? We all read the Wall Street Journal story on ABA therapy, and we're aghast, right? We found many other, unfortunately, we found many other incidents of rampant waste, fraud, and abuse by providers, whether they're federally qualified health centers who are charging $600 a visit, or whether they're home and community-based services that are amping up they're fictionalizing their care. We have to be better at stopping that. And unfortunately, for those providers in the room who don't do that, you all get lumped in the same barrel, right? And I understand that is probably unfair, but I know no other way, right? Unless the public has confidence in our programs, the public will end the programs if they do not feel that we are managing them prudently. And so for those of you who feel that we have been disrespectful to our providers, we need our providers, because the only care the only care that FSSA provides directly is at state hospitals. We buy everything else from you, and we need to do a better job of monitoring that. So we are in partnership with CMS and Oracle. This is the first in the nation piloting, and we are using that awful word AI. We are going to be using AI to work through claims, to find anomalies that may mean either improper billing or overt criminality. And so we'll see. CMS was here earlier this week. We dealt with this with them. We'll continue to do that. Brian Arrowwood on our staff, who's wearing a black hat somewhere here, is spearheading that for us. So as Lindsay properly pointed out, we can't talk enough about work requirements or community engagement, as it's euphemistically referred to. So let me be very direct. It is our job, it is FSSA's job, particularly it is Sunshine's and her team's job, to adjudicate whether or not the person who is seeking eligibility is in fact eligible. So let me walk through what needs to happen. So at a high level, let's say you or somebody that you care about is going to go into a DFR office in January and ask for Medicaid coverage. Good. They will need to document to us that they have worked in October, November, and December, at least 80 hours, or have $5,700 worth of income in school, at least part-time, or volunteering, right? They will need to document that. And that need for $580 a month? Oh, sorry. They will need to document that to our satisfaction. So that's this is an is, right? And so I encourage all the providers in the room who work with the folks on the HIP program to help your members remain eligible. It is not my desire to kick them off of HIP. I created HIP. I don't want them uninsured. But the General Assembly and the legislature have told us, and the federal government have told us to do work requirements, and we will do that. Very important that they know the exceptions, right? Very important they know the exemptions here. And the biggest one's going to be medical frailty, right? So I'm reticent to do this in front of my staff because I'll screw it up and they'll laugh at me. But you will need to be functionally unable to work. So simply having diabetes, if you can work, right, that does not exempt you. If for some reason you become medically frail during the course of your eligibility, you need to let us know that, right? So we can mark you as medically frail and not subject to work requirements. Again, this is the responsibility of the recipient. They are called able-bodied adults, right? And they have that responsibility. Let me close with this request, and this is really a request that is less about HIP and more about Hoosier Health-wise, and that is particularly, and there are folks here who represent the disabled community, making sure that disabled children get on the right category of Medicaid. I cannot emphasize it enough that if you get to a certain age and you've been cruising along on Hoosier Health-wise, right? You get to a certain age and you're not eligible for a number of services you've become reliant on. So I see this all the time. I talk to our DFR staff about it. Please make sure your children and the people that you work with are on the right kind of Medicaid, because otherwise it's just there's nothing we can do. If they're not on the right and the right kind of Medicaid, they'll age out and they're stuck. So not a good situation. So I encourage you to do that. We do have a portal. Lindsay referenced the portal. I think Sunshine referenced the portal. I'll reference the portal. Understand the portal. Help people work the portal. The portal is going to be their best friend. The goal remains getting to 2%. That's not an easy goal to get to. If it were easy, they'd send the children. But we're John Belushi walking through that cafeteria aisle. We need to be leaving a little more behind for K through 12 and higher ed than we have. So thanks very much. It's been a terrific day. Again, thanks to all of your help to get us to back in black, and please don't let me go under again. Okay. Happy to answer questions if you have any.
Question, just please raise your hand and I will get you a microphone. Okay, I don't think I see anyone.
How can there not be a question?
The presentation was that good.
No. There's a gentleman right.
Okay, we got a question.
Well, it's being broadcast, yeah. Plus Marcus needs the exercise. He's getting kind of fat.
So in the past, with this 2%, you've referred to if different areas could keep their area at 2%, that maybe they would be able to keep that within. I'm not saying that very articulately, but for example, in the CIH waiver,
yeah,
if we waiver providers can keep that at 2%, then are we pretty well assured that there won't be any issues with future rate cuts, that kind of thing?
So and Kim remembers this from last time I was here. Kim Dotson, ladies and gentlemen, thank you for being here. Last time I was here, we said inside the quadrants, right? If you save money, we wouldn't do that. I wasn't sure that I could guarantee that that would be the case this time around, at least for the next biennium, it will be, right? We have visibility to relative stability in the next biennium. It is the biennium after that which becomes more problematic because we'll start to see a step down in the hospital assessment fee. And the hospital assessment fee, we pull 315 million last year, maybe 400 plus million this year. And that really helps fund the rest of the Medicaid program. So if I don't have that money, that's going to be more of a problem. But so you'll see as we proceed here, we did, as you may know, we did 4 years projection last time. In December, we will do a subsequent, actually be a 4.5-year projection. Project the rest of this fiscal year and the following 4 fiscal years, because unfortunately, it's not like Medicaid's going to go away, right? It's going to be there those next fiscal years, and the changes that we made last year in care, what Lindsay's, the 10,000 or more that Lindsay moved from non-dual status to dual status, those savings won't be recognized until the current fiscal year. So there's FSSA, it takes a long time to move.
We have a written question. Why is 2% the magic number? How did you get to that number?
Great question. I got to it because it's what my milk has, fat in it. No, I got to it because it's the growth rate of the general fund on a regular basis. Right? General fund generally grows at 2%, right? If it grew, if the magic of AI actually happens and we have tremendously increased productivity in the country and in the state, and it's growing at 4%, great, it can grow 4%, but it's the percentage that we take that 2% tends to be the long-term growth rate of the Indiana General Fund. That's how I got there. Just be glad I didn't drink skim milk.
Do we have any other questions? Okay, thank you very much.
Thanks, guys.